refractive surgery. And in this webinar, we have the privilege of having some very eminent speakers. We have with us Professor Mahipal Sachdev, who is the president of AIOS and the chairman and managing director, Center for Sight Group of Eye Hospitals. We have Professor Jeevan Estitial, who is the president of ICRS and the professor and head Cataract, Cornea, and Refractive Surgery Services at RP Center, AIMS, New Delhi. We have with us Dr. Rishi Mohan, who is vice president of ICRS, and he's the senior consultant at MMI Tech Institute in the Cornea, Cataract, and Refractive Surgery Services. We have Dr. Rajiv Mukherjee, who is the treasurer of ICRS, and he is director and senior consultant eye surgeon, Mukherjee Eye Clinic. No. We have Dr. Ambarish Darak, who is the chairman of Vision Next Foundation at Pune. Then we have Professor Namrata Sharma, who is the chairman scientific committee of ICRS and honorary secretary of AIOS, and the professor of ophthalmology in the Cataract, Cornea, and Refractive Surgery Services at RP Center, AIMS. Then we have Dr. Chitra Ramamurthy, who is the chairman of ARC AIOS and the medical director, Eye Foundation, Coimbatore. We have Dr. Leonardo Torquetti, who is the chairman at the Center of Excellence in Ophthalmology, Sao Paulo, Brazil. Then we have Dr. Anant D, who is the director and senior refractive surgeon at Lotus Eye Hospital, Coimbatore. We have Dr. Hossam Zaida, who is professor of ophthalmology in the Department of Ophthalmology at Al-Azhar University, Egypt. Then we have Dr. Ritika Sachdev, who is joint secretary, joint treasurer, ICRS, and additional director, medical services, Center for Sight Group of Eye Hospitals. And we have Dr. Sujata Das, who is the medical director, Drishtidan Eye Bank at L.V. Prasad Eye Institute, Bhubaneswar. So we begin the proceedings with the first speaker, who is Professor Mahipal Sachdev, who will be talking about flap complications in LASIK.
Thank you very much, Professor Rajesh Sinha. I think it's a pleasure being here, and I wish to thank ICRS, Dr. Titial, Dr. Rajesh Sinha, Namrata, Dr. Ritika, etc. for having me here. And I wish to express our sincere gratitude to Leonardo and to Hossam, both dear friends. We spent some time together in Egypt and hope that they are well. I think Sao Paulo is also having lots and lots of cases as they are surging in India, and we hope that they stay safe and stay healthy. Pleasure being in this particular refractive surgery complication webinar. So it is very important for us to know the refractive surgery complications. The basic thing that one has to remember that refractive surgery is done on otherwise normal eyes. And in case these normal eyes undergo complications, then it is something that normally is not taken very nicely. So what we have to do is to know what the complications are, why they occur, and how to treat them. So I think my talk is going to be basis the LASIK complications of the flap that are there. So I'll be talking about the flap complication as to what are the challenges that one can have and how to take care of them. Now, when you are looking at LASIK complications, these are the refractive complications, which I'll not be talking about. This is basis the laser which are there, which I'll not be talking about.
Sir, your slides are not visible.
Sorry?
Slides are not visible.
I've already shared, no?
No, it's not there, sir.
Okay. 1 second.
Slides are not there.
1 second, sorry. It'll take me a second. I'll just need to get out and again open my PowerPoint. Just give me a second.
Yes.
Are they coming now?
Yeah.
Okay, sorry.
Yes.
Okay, so I'll be talking about the complications of LASIK, and I was talking about you could have refractive complications, you could have complications because of the laser, and you could have complications because of the flap. So my brief today is to talk about the flap complications, and I'll be making it more of a video-based presentation as to what are the complications and how we can kind of take care of them. Now, let us just look at this first complication. This is a case in nothing abnormal in the pre-op this thing. The keratometry was also fine, and it was a new keratome that we were kind of working on, and this is the marking that we have done. And now you can see that this keratome goes flawlessly. There's no problem. But if you look right here, there is a raw surface, and the important thing that I'm trying to tell you is that this is a total free flap. So you should not kind of jerk your microkeratome off. That is going to be a problem if supposing the flap is stuck there at a particular time. So be very gentle and careful and do this. Now, I normally, because of the several years of experience, I am not nowadays using the ink to kind of stain it, but I did mark it. So that is very important that you should be using the stain, but the marks are going to be of help. So now you see that we are trying to look at this cut end matching with this cut end. So the geography of the flap is something which is very, very important that you can look at. So you can see this. If you try to match this, this will also match. But what important thing that is there is that once we dry up the flap, you get the stromal irregularity. So I am very sure now that the flap is upside down. So it is very, very important that the flap should be placed properly. So what we have done is that we have put the flap now upside down and have then tried to keep the flap in the proper position. So you will need to just wash any interface debris, and then you have to be very gentle that the flap does not get dislocated. Now you can see that I'm going to try and match this particular area. Plus, in due course of time, you will just see, I'll just forwarding it. You can see here that this is the line. These are the marked lines. If you can see, this is the marked line that is there. If there was ink, then you could have seen it a little better, but you can see that these are the marked lines. So I am trying to make these together. Again, you can see there is one here, and this is the area from where we got the free flap. So all that all that I'm trying to tell you is that the surface should not be upside down. If there is a mark, you have to adjust the marks, and then you have to wait for a much longer time. And after you have waited for a much longer time, see here, these are the marks which are coming pretty well. After you have waited for a much longer time, the flap would stick well as it does normally, until of course you have a very bad flap, which I'll just show you in the next video. And in this particular case, you can see that the flap sticks very well, and you just need to put a contact lens on there. And couple of days, it depends on how much you want to wait. Anywhere between 48 to 72 hours you can wait. And you can see, ask the patient to blink several times so that there is no movement of the flap. Keep the patient in the center for about at least an hour, and again see that the flap is in position. And you can see that post-operatively, you can't even make out that there was a problem of a free flap. So this is something that you can do. Now, suturing, therefore, what I am saying is that it's a clean cut flap. Suturing is really not essential. Now, let us see this particular case. Was referred to from outside that the flap has been put. So obviously the flap had been put in this particular case. There was possibly a problem that was there, and the flap obviously is showing a lot of problems, and it is not well stuck as in the previous case. You can see this is the previous case, and this is this case, and obviously this is not well stuck. So what do we take the patient to the OR, and this is, I think, came to me about 96 hours or 72 hours after the procedure. There is a bandage contact lens in position. But what I'm trying to emphasize in this particular case is that it is not a good, nice flap that has been made. So in this particular case, just by putting the flap, you would not be able to get an adhesion. Now, if you look at this particular point, the backside of the contact lens has the flap. I'll just pause it here. If you see this particular line here, this particular line is showing you that possibly there is a biplanar flap that has happened. So again, here you can see that it's a biplanar flap. Even though I spoke to the surgeon said that there was no problem as regards why it should be biplanar. But my suspicion is that there is a possibility that there was a suction loss or the water got stuck the motor went back, and then again the motor was put back again to work. So therefore the planes at which the flap has gone are different. So these are two different flaps. So what I try to do is that I try to push this back. You can see here there was some loose stroma which I have taken out, and I try to separate it and put this flap. So I'll just do it fast forward. But in this particular case, because the flap was not sticking, it's not a clean flap, and now in any case it's 72 to 96 hours. There is edema of the flap, so there is no way that it can stick. So I just suture it up and put the flap thinking that everything should be all right. So you can see it looks pretty all right. Next day you can see there, though there are wrinkles etc which is there, but over time 3 weeks later the flap started to melt. There were some sutures with gave way and the flap started to melt. So we actually sacrificed the flap, and you can see after sacrificing the flap, the cornea is really some cornea which is really forgiving until the patient was in follow-up, and then patient was from outstation, has left, so the patient had improved to 6/9 partial vision. So if you have bad flaps, you might have to kind of discard those flaps because it does not make a lot of difference as regards the refractive outcome. Now, if you have a position like this in a LASIK flap, you see a central opacification, some kind of, you see that it's an inflammatory reaction. There can be two things to it. It can either be a very severe form of DLK where you will see a sands of Sahara, or it could be a central toxic keratopathy. So whatever it is, I think you have to intervene fast. You can easily lift up the flap as has been lifted up in this particular case. And you will have to wash this. You can put antibiotic there, and you need to wash it, remove whatever are the reasons for this toxic reaction in the DLK. Just wash it very well and just see that the flap sticks well. And this obviously the entire, there has been some collagenetic activity that has been there, so it will take a little while to go, and you have to keep them on long-term post-operative steroids, and things will be fine. I just saw that Dr. Ritika is going to talk about ectasia, so I am not going to talk about this, though I had some slides, so I'm just going forward. Now let us just see the complications of flap that you can have with a femtosecond laser. So these are complications of flap now with a femtosecond laser. Now, if you see in a femtosecond laser, the biggest advantage of a femtosecond laser is that you can actually recut at the same particular time. In the learning that I showed you in one of the flaps was that if you lose suction in a microkeratome, you have to abort the procedure and you cannot cut at the same time. Now, if you see this particular case, you can see that this is an FS60. So we had got hold of the FS60 somewhere in 2006. So it's pretty slow now, as it's the it's the second or the third model of the intralase that was there. And I think we were the first to put this in Southeast Asia. Now you see that there was a AC failure, and I just continued. We didn't know at that particular time, and the machine just stopped. So the machine can stop, you can lose suction, etc. We put on the AC, it's again, temperature cooled down. Once the temperature came back, you can use the same cone, you can use the same settings, but pocket off. So you can see this was a pocket earlier, so it is pocket off now. And with pocket off, we are going at the same depth. Now you can see that this progresses very well. I'll just fast forward it. So you can see that it progresses very well. And we are able to continue the procedure without aborting it. So you see that this is fine now. And the only difference that I have in the flap is that normally I start separating the flap from the superior part, but in this case, I'll separate from the inferior. Now you can see this has more OBL than the lower part. So this is where the double pass had happened, which is that the laser had fired twice at this particular place instead of firing once. So we are doing the side cut. Side cut was only once, so there is no problem in doing the side cut. So all that I will try to show you here is that once we have the spatula go into the side cut, I will start my separation from the lower part. So I'll just dry it up because there's some bleeding that is there, a lot of pannus that is there. So let me just go fast forward in this particular case, and you can see that I am going from below the second pass. So in case there was any lamellar dissection, which normally does not happen, this was the first time that I did it way back in 2006 or 7, and we lift it from below. So they are pretty simple as regards the femto, because you don't actually have slivering or anything, And from the bottom up, you can see that we can easily separate. And as you can see that there is no problem, there is no lamellar dissection or anything, it goes in the same plane. So once the OBL has been formed, if you have kept it at the same depth, the laser pulses will go into the same plane and there is usually not a problem. So we did the laser and completed this patient here. Now in this particular case, let us just see what is important when you are doing a femto is that you need to look at corneal opacities. Because if there is a corneal opacity, the laser loses its track and it does not go properly well. So can you see this? This is a bubble, a cut through that has happened because there is a corneal opacity at this particular point, which was we thought it was not of any great clinical significance. So as we are separating and we saw that bubble coming up, which was a cut through, you can see that this is a non-cut area of the cornea. And we go from the other side now, and we try to retrieve and see as to how much of the flap has been lifted. So this will be an uncut area, but rest of the flap gets lifted up with an uncut area here. So normally, again, the cornea is very, very forgiving. And since it is in the periphery, you can see this is in the periphery, there's no way that I can separate this uncut area. So you will see an island of uncut area. You can see this is an island of uncut area. We go ahead, do the laser because it's in the periphery. And once the laser is done, you just put back the flap and make it dry. Just wait for a little longer and maybe put a contact lens and you will get an excellent result in this particular case also. So just be mindful of corneal opacities that they can cause you problems. Now this is the next case where if you have an interface debris, in case of a femto, there is a problem, and if the interface debris is mild, it does not matter. But in this particular case, which is a large cilia of a patient, you can see that the cilia is here, and despite the cilia being there, the process is being continued, which is wrong. So if you have a cilia like this, you should actually stop the procedure, not start the procedure, and you should remove this cilia. And you can see that this will be a cold spot. This will be uncut because the femto laser cannot penetrate through this. Let me just go forward. And we did have dissection difficulty. So you can see that we are having dissection difficulty at this particular point. And the patient, basically we could separate it, but there was a flap tear here. So if you see, we are separating it. And you see here, again, difficulty, you can see the cilia is totally, you can see that this cilia is where it was. And these are non-cut areas. So we are being very careful and we have been able to dissect the flap, but there is a tear in the flap. Now, since the surface is all right, reasonably all right, we went ahead and did the laser, put back the flap and really tried to just oppose the ends of the tear, which is there, which did get opposed. Put a contact lens in this patient, and again, this patient behaved very well. Though there is a marginal tear which is going in the pupillary ring, but this patient came on and went on to a 6/6 partial vision. But please put a contact lens and be careful to remove it. Now, the femto laser also can have a problem which is really not something that you should be bothered about. But from the collector channels, you can see that the patient, if you are doing a femto, the patient can actually have air coming into the anterior chamber. So this you can see as is being completed here. As we lift up the cone, what you will see after the completion is that there is a bubble of the air in the anterior chamber. Can you see this? Now this either you can keep waiting for, because it's a reasonably large bubble, it will take a couple of hours to kind of disappear, or you can have the tracker off. So we just put the tracker off and went ahead and did the laser, and next day the bubble was not there. It does not impede the ablation process, but yes, the tracking process it impedes, and that is a problem that can be there. Now this is a patient, 35-year-old female. Now this why I am showing this is that you need to be very aggressive. This patient is 35-year-old. LASIK was done in 2009. Elsewhere, and the patient developed flap folds. The patient went to a premier institution in August 2009, and there was a wash that was done, and the flap was repositioned, thinking that the flap folds would go. But just doing a wash never solved the problem. The patient still had a BCVA of 618. She was a teacher, and she came to me with a lot of problem. Now you can see that this is despite an attempt being made at that particular time in 2009, I think, to take out the flap folds. So you have to actually classify the flap folds, whether they are macro folds or micro folds, and see it on retro illumination on a dilated pupil. And even when you are removing the flap folds, it should ideally be done in retro illumination of the microscope, and it should be done with a fully dilated pupil, because you will see these folds much better. Now, these are the folds which are there. Once important thing, you have to totally remove the epithelium. As long as the epithelium is there, it will anchor onto the folds and it will not allow the folds to be taken care of. So you remove the entire epithelium. Once you have removed the entire epithelium, you have to actually go ahead, lift the flap from the anchorage below. So actually all the folds, whether they are anchored down or they are up, that needs to be taken care of. And then you have to start using hypotonic saline. So you have to swell up the flap. You have to cause hydration of the flap. And then you have to use 2 Merisol sponges and try to do them perpendicularly to take out the flaps. And this takes a lot of time. And you have to keep on hydrating the cornea with hypotonic saline. After that, you will actually need to, if you want to put a suture, you can, but it is not required. But you can see that the intensity of the folds have gone down. And once you do this and you put a contact lens, over time, the next day, the folds will never disappear on the table, but you have to put adequate pressure to try to remove the folds, hydrate the cornea, remove the epithelium, disengage it from the bottom also. And you see that this is what the patient went on post-op visual acuity 6-7.5, and she's happy, and the folds have gone, and that is something which is very, very important. So friends, I have shown you a couple of things that you can see as regards the fold complications, or the complications as regards the flap, both for the mechanical microkeratome as also of the femto-LASIK. I have switched on totally to the smile, and since Dr. Tityal was to talk about smile complications, I did not go into that. But a lot of us still have the making of the flap as their treatment of choice. So you need to be aware of it. So finally, I'll just say that challenges are what makes life interesting, but overcoming them is what makes it meaningful. So thank you very much for your kind attention.
Thank you, sir. That was a wonderful presentation on flap complications. And we will have questions for you. There's one interesting question that has come up because people are watching in YouTube as well as Facebook and here at the Zoom platform as well. So there's one question that has come up, and that is that if the flap free cap that you showed, that you positioned it back, if it's lost or damaged, then what would you like to do?
So that is what Dr. Rajesh, I showed in the next video, that you have to assess the integrity of the flap that has been made as to how well it has been made, whether it is biplanar, whether there is a loss of tissue, etc., etc. If it is very thin, it is never going to stick. So the thickness of the flap, the integrity of the flap, whether it is round, circular, etc., what exactly has happened has to be seen. You may require 1 or 2 sutures, as I did, and if it's a fresh cut, you can put an anti-talk suture and then you can leave it and then it sticks back. But one thing that is there is that even if you discard the flap, it does not impact the refractive outcomes to a large extent. Okay, so that is very, very clear that we need to be very careful as regards examination and take all measures that till you actually see the flap under the microscope, the surface that it is all right and the flap is good. Do not make jerky movements in your microkeratome. So situational analysis is very, very important before you decide on your way forward.
Absolutely. Dr. Rishi, you want to say something?
No, I think it's an excellent presentation, and I think the most important routine sort of a complication that one does get is striae. I think that is by far I think with the new keratomes, we're pretty much done with the free flaps, and unless there are abnormal topographies to start with. But yes, striae and folds are something that we see very often. This patient rubs his eye in the post-operative period and can come back with a late fold as well. And I think that was an excellent video of what Dr. Mahipal showed about how to correct these folds and how to treat these in the later stage. If it's early folds and you see them the microstriae right up front on the first day, then sometimes a simple wash can do it. But if it's more than 24 hours, I think almost certainly you have to deepithelialize and do the whole job like has been shown.
Yeah, I think Rishi, you are absolutely bang on. Again, you have to assess, and the folds, once they become fixed, it will not work without removing the epithelium. But microfolds, if they are, sometimes the person has rubbed and it is extremely in the periphery, you can forget about it if it is not coming to the visual axis. But you have to assess, and that's what I said. Vision problems of the, sometimes you see microfolds and you say that the patient is unhappy. Like there was a patient I just did recently, 2 years ago. The procedure was done somewhere else. They have been from the same surgeon again and again, and the surgeon is saying that no, this is all right, this is all right, and things like that. And the patient was going almost on the verge of depression. So what is very, very important is that they can be highly symptomatic to a patient. They can disturb the patient significantly. And what is important is that you have to dilate the pupil and you have to do a good retroillumination to see the depth of the fold, the intensity, and the location of the fold. Central folds are very, very bad. And then you have to think of intervening, and never postpone an intervention in a flap fold if it has to be done. It is done better earlier than later.
Absolutely. Thank you, sir. Now we move on to the next speaker, and there's a slight alteration sequence.
Rajesh?
Yes.
Okay, can I ask a small question?
Yeah.
To Dr. Mahibal, thank you for this great presentation, but I would ask about the time you can stay for the medical treatment with the microfolds. If you have a patient with microfolds after surgery, but it's symptomatic, but with very insignificant symptoms, some blurring of vision, which could be from the dryness itself. What the time to wait for the intervention in such case?
I don't wait. If the patient is symptomatic, the dryness and all, I think is a minor thing. If there are folds which are coming in the center of the pupil and the patient is symptomatic, it is not because of dryness, because these are typical symptoms which a patient has of distortion, blurring, headache, and the other thing is you don't get a brisk refraction. That is also something very important, and you don't get the patient to 6/6 vision often. More often than not, it is 6/6 partial or 6/9 or whatever it is. So those things I would not wish to wait. I never disregard the symptoms of the patient. Yes, a lot of times you tell the patient it will be all right, it will be all right, but you have to do a clinical assessment. And if the microfolds are in the center and they are actually going on to macrofolds, then under those circumstances, I'll intervene early. Otherwise, yes, that's what I said. If they are peripheral, not coming to the center, microfolds, etc., you could possibly leave them and think about it. But if the patient is constantly symptomatic, then you should go ahead and intervene, because there is nothing much that is lost in intervening. The patient will have discomfort for 2-3 days. And if, like Dr. Rishi said, if you do it on the first day, you have to do really, you don't have to debride the epithelium and things like that. Just a simple maneuver of spreading out the flap, etc., and doing a wash and spreading out the flap, that can happen. But in my case, though the patient went for flap removal, just spreading out the flap to remove the macrofolds or the microfolds that were there for long will never work. So there you have to remove the epithelium. So it is definitely, if you do it in the first 24 hours, you can get away without removing the epithelium, but 48, 72 hours onwards, you will have to remove the epithelium.
Yeah, in case of removal of the epithelium, there is any measure to avoid the epithelial ingrowth after re-lifting the flap?
Yes, so that is exactly a point. So the longer the flap is there, the longer it you have tried to remove it, there is the onset of a corneal edema at that particular point of at the junction of the flap. A fresh cut gives you a very good, excellent apposition, but a flap that has been relifted gives you less or poorer apposition. Therefore, even in enhancement, a lot of people say that if you have done a femto enhancement, you can actually do a new cut from inside and lift it up, so that chances of epithelium growth, ingrowth becomes less. So number of times that you have lifted the flap, hydration of the flap, which has to happen for flap folds, can increase the incidence of epithelial ingrowth. And usually there is a little bit of epithelial ingrowth that does happen, but normally if you have waited long enough and put the flap back, it does not grow into the center and it does not increase, and that it remains all right. So what is very important is to put a bandage contact lens also in these cases and see that there is no epithelial ingrowth, that you have to wait.
Okay, thank you very much. Thank you.
Yeah. Thank you. Thank you, Dr. Mahipal. And now we move on to the next speaker, and that is Dr. Namrata Sharma. And she'll be talking about post-LASIK epithelial ingrowth.
Thank you, Rajesh, and thank you, Professor Tritial, for this wonderful webinar on complications of refractive surgery. I'll be talking to you about epithelial ingrowth after LASIK, and although it's a rare complication, but sometimes it can be really recalcitrant. And it occurs mainly because of the active proliferation of the epithelium at the flap edge, and it grows under the flap into the interface. Now, generally, the incidence in the older studies, if you see, was when microkeratome LASIK was used, was 0 to 20% of the patients, as per the study from 2002. Most cases are self-limited, and surgical treatment is required in 0.9 to 3.2% of the cases. And it is visually significant again in 0 to 3% of the cases in primary, when you do a primary surgery. But when you do a repeat surgery, especially after microkeratome LASIK, then the incidence of visually significant epithelial growth increases 1.7 to 23%. It is generally less with femtolasic, and there are in the PubMed there are 2 case reports which have been published of epithelial ingrowth after SMILE, and this is one of those cases. And I think there may be more which have not been reported, but in general it does have less chance because there is no flap. So the factors could be preoperative, which could be surgeon factor. It occurs more with the hyperopic LASIK because the ablation occurs in the mid-periphery. So possibly the flap position is not as good as in a myopic LASIK where it occurs centrally. More with the anterior basement membrane dystrophy cases, older patient age group, and type 1 diabetes. Then there could be risk factors which could be intraoperative, such as epithelial defects, where it increases in one of the studies to as high as 33%, flap dislocation due to trauma or due to poor adhesion, when excessive manipulation has been done, or when there is a buttonhole, such as in this case, and you can see that there is a epithelial ingrowth which has occurred inside the buttonhole. Whenever there is laser ablation of the corneal epithelium at the border of the flap, or whenever hinge inadvertently gets ablated, and in all cases of repeat LASIK, this was a case of repeat LASIK, and notice that there is so much of epithelial ingrowth which has occurred, and even through the RK wounds, the chances of epithelial ingrowth are much more. So it has been classified into various grades. Grade 1 is when you have those small white aggregates, smooth outlines, which are just limited to 1 millimeter, 2 millimeter from the flap edge, and they are outlined by a demarcation line, and generally they will remain in the periphery and not progress. And you might see this generally in some of the cases, but no treatment is required, and they normally disappear within 2 to 4 months. Then grade 2 is when they are pearly white aggregates with blurred edges, which are located within 2 millimeter from the flap edge. The ingrowth is thicker and may progress towards the center of the pupil, and this requires observation because if it encroaches the pupillary axis, you may have to intervene. Grade 3 is when the ingrowth is marked with the multicellular thickness and extends more than 2 millimeters with thinning or melting of the flap, as is shown here. And grade 4 is when there's aggressive growth with strands of epithelial cells which are invading in the visual axis. This may result even in a flap melt or keratolysis, and so one has to be careful, and urgent treatment is required in these cases. So generally these patients, some of them may complain of foreign body sensation and glare, and generally in these cases you will not interfere if it is just about foreign body sensation, but when it is progressing towards the visual axis and has irregular and uncorrectable astigmatism, or there's a flap melt or keratolysis, then in these cases you have to intervene. The surgical options are many, and because it's not very common, so there are not too many studies with large number of cases. Most of them are anecdotal reports, few are case series, and none of them are randomized controlled trials. So although various options have been tried, but in general, these procedures have not been compared. Flap elevation and debridement of the epithelial tissue can be done, but the recurrence rate may be as high as 44%. In order to obviate the recurrence, additional therapy by the use of 20 to 70% alcohol to kill the epithelial cells have been tried in various studies. Then PTK also has been done. 0.02% mitomycin can also be used. And for epithelial ingrowth, which are not that aggressive, YAG or argon laser has been used to kill the epithelial cells, and suturing of the flap may have to be done in some of the cases where it is really recalcitrant or where it recurs just to close the gap so that there is no conduit for the epithelial cells, this may be required. Now, whenever additive therapy has been used, there have been some problems. For instance, in cases where 20% alcohol for 30 seconds was used, there was some amount of corneal haze. Where short pulses of excimer laser PTK was used, it was associated with irregular astigmatism. And where people use the neodymium YAG laser, again, this has a limitation, cannot be used for very florid ones, 0.7 millijoules, multiple sessions are required, and retreatment is required in 40% of the cases. And also 0.02% mitomycin can be applied for 20 seconds. And in one study, they have even combined it with PTK after lifting the flap and the epithelial debridement. So just to go by cases, if there is a case like this, you can see that there's a small epithelial ingrowth which is present right in the periphery, and there is a island here, and there are small satellite lesions which are present here. So this can be just washed because it is in the periphery and it is not going to the visual axis. Now this is a large one which is encroaching the visual axis. This was a case which was referred to us, and if you look at the slit lamp examination, notice that it is so aggressive looking. On fluorescein staining, it will stain. And this is the anterior segment OCT. You can see that the epithelial ingrowth is there. So in this case, in these cases, one can do flap elevation with tissue debridement, and 0.02% mitomycin C can be used, as was done in this case. So this is the flap which is being removed. And sometimes the part of the epithelial ingrowth can be recalcitrant, and other times it can be very gelatinous. This was the one which was very gelatinous, and it was important not only to remove this from the bed, but also to remove it from the undersurface of the flap. And then subsequently, mitomycin can be used 0.02% for 20 seconds on the bed as well as on the undersurface of the flap. And this can be copiously washed. And again, the mitomycin can be used on the undersurface of the flap. And then this was subsequently sutured with the help of 10-0 monofilament nylon sutures because of the angry looking epithelial ingrowth. And this was the outcome on day one. Obviously, it would go away on day one, and we don't expect it to be there. And this is the post-op ASOCT picture. But important thing is the follow-up, which occurs in the later time, in the later period, where it doesn't recur. This is the only study which I could find, a retrospective study of 67 eyes, which compared flap lift plus scraping versus lift plus scraping and suturing. And in these cases, it was found that the visual acuity results and refraction was better in those cases where no sutures were put, which is understandable because there's no astigmatism. At 1 year, however, the results were comparable, and the recurrence rate was more in those cases where no suture was put. So, but in terms of long-term visual outcomes, both the techniques were comparable. Now, this is yet another case in which repeat LASIK was done, and there was a epithelial ingrowth which was present. And the patient came after some time, didn't want to get surgery because at that point in time he was 6'6", then came again, and this is now, there's some amount of melt also which is incited there. And this was removed, but after removing it and washing it also, it started to recur after 6 months time. And then again, it went into a keratolysis kind of a picture. And this was the anterior segment OCT picture. And now this patient is awaiting a lamellar procedure following after the lockdown opens up. Now then you can also do neodymium YAG laser such as this, and you can see the air bubbles with the YAG laser. Then you can also do PTK with short pulses of excimer laser. The PTK can be done on the flap or the bed, and it can be associated with irregular astigmatism. Here in this case, we did PRK because the refractive error was only -2, so we were able to get away with it, and this was removed. And of course, prevention is better than cure. So avoid prolonged manipulation of the flap, clear any epithelium tags or debris from the stromal bed prior to flap reposition, shield the hinge area, apply contact lens when epithelial defects are observed, and femtosecond laser flap is better than a microkeratome flap with less epithelial ingrowth. So to conclude, it is important to recognize and manage the post-LASIK epithelial ingrowth, understand both the modifiable and the non-modifiable factors which help to reduce the incidence. When appropriately managed, you do have good visual results, and additional measures and interventions may be required in aggressive or refractory cases in order to achieve complete and permanent eradication of the disease. So this is just to show the results which have come in the recent article, that the results are not that bad, they are quite good. The only thing is that the recurrence may occur, which ranges from 0 to 36%, and in a couple of cases which are anecdotal, almost 100%. So thank you very much for your kind attention, and if there are any questions, I would be happy to take them.
Thank you, Dr. Namrata. It was a very nice overview on the management of epithelial ingrowth, which can be seen in LASIK or repeat LASIK. There's one question for you, and that is regarding laser. How do you use this laser? You have mentioned about it that ND-YAG laser can be used to, hit the epithelium. So minimum, yeah, please go ahead.
So ND-YAG laser can be used to hit the interface actually where this epithelial cells are there, and 0.07 millijoules is the energy that has been recommended. And you know that you've reached that area once you get those air bubbles inside that interface. So you have to focus it there. But having said this, the chances of recurrence rate with this neodymium YAG laser are high. And so we have not done this in any of our cases, but it has been described.
So this is just a procedure wherein you don't lift the flap and focus it and hit it with ND-YAG laser. Thank you very much, Dr. Namrata. And I know you have to leave, I guess, for some other meeting.
I think both of us have to leave. So in case there is anything for me also, we'll be leaving. Okay.
So I would like to thank both of you for being here. And so we continue with our next speaker. And that is Dr. Anant, and he'll be talking about regression following laser refractive surgery.
So good evening, everyone. Is it audible, sir? So Sarve Jana Sukhino Bhavantu. I think majority of us have started off with our practice. Well then, stay safe. And thank you, ICRS team, and especially Rajesh sir, for giving me this opportunity. And I'll be speaking upon this topic, regression following laser refractive surgery. For the next 5 to 6 minutes, I'll be trying to cover this topic in a very simple and practical way, keeping all sorts of viewers in mind. So first, we need to understand what is this regression. It is nothing but the tendency of an eye to reverse back to its original refractive status post-operatively. Here, we need to exclude where the refraction is getting unstabilized and there is a plastic deformity of the cornea. Whenever there is a power comeback, we need to have 3 things in mind: regression, progression of the refractive error, and ectasia. In the regression, always the BCVA will be very well maintained. There will be absence of the scissor reflex. Both spherical and cylindrical component can increase and axial length would not have been changed. But if it is a progressive myopia, if the power comes back, there will be change in the BCVA, there will be absence of split reflex, only spherical component tries to increase, and when we document axial length, there will be significant change in the axial length. That becomes the reason for power comeback. If it is a power comeback because of ectasia, there will be loss of BCVA, significant jump in the cylindrical power, and early split reflex starts appearing, and there will be no change in the axial length. So to know about regression, it typically starts between 3 to 6 months. There are some cases where it has gone until first 2 years also. And more so, this happens with hyperopic corrections when compared to myopic corrections. And incidences of regression are more with lower myopes when compared to higher myopes. But recently, some studies have come up where even higher myopes are also landing up with regression. The incidence is variable and it is not so much published in the literature, but it varies between 0.5 to 2.2%. But the enhancement rate is half the incidence of regression. And this typically happens more with the spherical corrections when compared to the cylindrical this thing. And it happens more with the PRK procedure rather than the LASIK procedure. And recently, some paper are published that even the rates of regression with LASIK is almost similar to the rates of PRK regression. And it's a known fact that always regression happens whenever we choose a smaller optical zone less than 5.5 or 5.8. And there's a strong correlation whenever we leave a restral stromal bed less than 350. The tendency of regression reduces when we leave a restral stromal bed thickness more than 350. Just for the beginners to understand, this is how the regression happens. For example, we have done a LASIK for -3. Immediate first week post-op, he will be imetropic. With 1 month, he comes with 0.5. At 3 months, the refraction of -1. At the end of 6 months, he comes with 1.5, then stable after. This is how a regression case follows. We need to understand what are the causes and what are the hypotheses which are blamed for this regression to happen. The first one is epithelial hyperplasia. Second one is decreased flap thickness. Because of the vicinity between the flap and this thing, so many growth factors are released which can provoke epithelial hyperplasia. And the third one is stromal remodeling. And whenever the late regressions happen, we need to always keep in mind the lenticular nuclear sclerosis. Old age, in my experience, I have seen few patients of regression. Whenever I've taken up a patient more than 38 years of age, and the same happens with literature also. Old age is also a risk factor for regression. Smaller ablative zone, as I mentioned, has got a bigger tendency to land up in a regression. And if you look into the annual rate of progression, it's more with hyperopia when compared to hyperopia. And whenever we plan a correction for these subset of patients, they should demonstrate a refractive stability between 2 separate visits. If it is unstable, it's better not to proceed. And once we decide to go ahead with the treatment for these patients, we need to have a very thorough evaluation. Manifest refraction, cycloplegic refraction is very, very important because patient may be depressed and he may have some accommodative issues also. Cycloplegic refraction to rule out all those accommodative issues. Dilated fundoscopy to rule out the choroidal thinning. Corneal topography, if we have access to epithelial mapping, it's better to epithelial mapping also. And most important, we rule out the drug history. There are few drugs which can bring about spurious myopia. This has to be ruled out before we take up these patients for the refractive correction. Post-operative dry eye is very, very important. We should make sure that the cornea is not taking up a single dot of stain before we do the operation. And excellent documentation is very important. And as I mentioned, fundoscopic examination. We should always say no to enhancement whenever there is a refractive instability. If the residual stromal bed thickness is less than 300, and see for the significant posterior elevation. If it is more than 50 microns, please do observe the cases along with the elevation changes and the refractive error and decide upon the procedure. If there's a significant changes, it could be an early case of hidden ectasias. And we have 2 options, either flap-based procedures or surface ablation. The most important thing that we should remember is the selection of the optical zone. Optical zone should be always similar to the initial treatment or bigger than this. If it is reduced, we land up in qualitative issues of the vision such as glaze and halos. In flap-based procedures, we have 2 options. You lift the original flap or recut the original flap. Flap lifting, it is possible with the microkeratome flaps. It's easy within the first 1 year of life. You need to identify the edge. You could see in Namrata Madam's or Dr. Maipal's video also, you could see. Identify the edge, you can pass the spatula. There will be small amount of resistance, but still you'll be able to separate and relift the flap. But it will be very difficult whenever you come across aggressive wound healing. If the time between the primary surgery and the relifting is more than a year, and if you have taken a bigger flap, because of the vascularization at the limbus, too much of inflammation, it may be difficult to relift the flap. And if you see fibrosis interface, as in case of Femtosecond, it becomes difficult. The advantages of flap lifting is you are ruling out all the complications which can happen with the microkeratome complications. And already cornea is flat, you are ruling out all those complications. But the disadvantages are, since the surgical time is more, we may introduce the infection. The chances of epithelial ingrowth increases to 2 to 5%. Since we are disturbing the Bowman's membrane, there could be a delayed visual recovery and the inflammatory process can be set up in terms of diffuse lamellar keratitis. This has to be kept on mind. Flap recut, if you are planning for a conventional microkeratome, you plan it after 18 months. If you are planning for a femto, you plan it after 1 year. And whenever we are planning for a recut with a femto, we need to reduce the diameter and increase the flap thickness. There are few doctors who practice by reducing diameter and also decreasing the flap. They call it as mini flap, but I prefer to reduce the diameter, increase the flap thickness and make a recut. The advantages of making a recut is it's easy, and those flaps which are made, they are very predictable and stable. But we should be very careful when we handling so that we do not land up in two planes. And disadvantages, sometimes you will end up having a free corneal edge between the two flap margins. And the last option, we have what is called a surface ablation, preferably LASIK with 18 to 20% alcohol exposure for 20 minutes. Don't be surprised if you put alcohol on a prior LASIK flap. Once you remove the epithelium, you find like a wavy Sands of Sahara kinds of picture. Ablate it. Don't forget to use 0.02% mitomycin to prevent the haze for 20 seconds. The only disadvantage with LASIK enhancement is delayed visual recovery. And these days, SMILE has been the trend for refractive surgery. Myself, I have done around 3,000 to 4,000 SMILE procedures, but till date, I have not enhanced any SMILE patient. Here, the concept is we have to convert the cap into the flap. A SMILE procedure is converted to the flap procedure, and it is called as surgery. So this is the keep home message, and just a tablet chart. And in my experience, it's around 0.5%, and I've written for 30 cases out of my 28,000 cases where I've done flap lift, recuts, and surface ablation. The reasons behind my less reoperations may be a thorough evaluation before the primary surgery, and majority of the patients, they got adapted to little myopic defect, and we were not keen on resurgeries, and at last because of good doctor-patient relationship. Thank you.
Thank you, Dr. Anant. That was really enlightening, and the results that you showed about your own cases was really very impressive. Any comment from the panelists? Can I have Dr. Ambrish Darak to comment on this? Can you just stop sharing, Dr. Anant?
Yes, Rajesh?
Yeah, please, Hussam.
Dr. Anant, thank you for this great and informative presentation. But my question is about the when you do a new recut, when you want to do a new flap, I think it's much safer to increase the diameter, not to decrease it, and to check first by the anterior segment OCT the flap thickness. If the case wasn't done by the femtosecond laser, the flap thickness mostly will not be accurate. I have two cases such this problem. I found that by the anterior segment OCT, the flap thickness was planned to be 110. I found it 160 microns. So we have to measure it first by the anterior segment OCT. But in such case, when you have a flap of 160 microns, you cannot increase the thickness of the flap. Am I right?
Yeah, I think it's better to go that way. And if your corneal thickness supports it, yes, it can be done. But I would prefer to reduce the thickness and do in majority of my cases. Reduce the diameter and do.
Okay, because if we increase the flap thickness, we'll take more from the corneal residual stromal bed, which will decrease the corneal power and decrease biomechanics. And so I think from my own experience, within 12 years of working in the refractive surgery, I didn't do redo by new flap except 2 cases, and the 2 cases were horrible because of the first thing. When I did re-flapping, getting a new flap with the femtosecond laser on top of the microkeratome flap, this flap was 160 microns, and I planned my femto flap to be 90 microns. So I was stuck in this case by getting 2 flaps, not one. When I tried to lift the new flap, I got 2 flaps, because in such case the flap is not healed properly all the time, even if it was done by the femto laser. So it will be terrible problem when you have 2 flaps lifted with your spatula. The surface will be unstable, it will be irregular, so the ablation will take you away from your plan or your target. So my own opinion, to do when you want to redo LASIK or you do enhancement, to lift the original flap, not to do another one. But you can care about the infection by the good disinfection and using of the proper antibiotic therapy. And about the epithelial ingrowth, you can do the same measures shown by the Dr. Namarta in her presentation. Also, the surface ablation. What's your opinion? What's your experience about the surface ablation on top of the flap?
It works out well. It does good.
Yeah, it does good as regard to the correction of the error. But what about the haze with your hand?
Yeah, with the 0.02% mitomycin for 20 seconds, I think I have not come across a haze. It works out well, which makes sure, since the Bowman's undulations, it appears as a beach, we need to wash away the mitomycin. We don't want to land up with the mitomycin toxicity. Application should be thoroughly washed and diesel has to be applied.
Okay, sir. Did you find that at the same rate of haze with the redo by surface ablation on top of the flap, the same incidence with the primary PRK?
Frankly, no. I think around 10 cases I might have done. Frankly, no. Even grade 1 haze didn't appear.
Yeah, okay. I found it with the
I guess in order to get the incidences, we may need very high number of cases to exactly say what is the exact incidence of haze in retreatments, surface retreatments.
And all the time we are searching for the original process for that, because the two procedures are surface ablation, but they are totally different in the incidence of haze. Okay, thank you very much for your great presentation, sir.
Dr. Amrish, you would like to comment on this?
I think there are 2 scenarios basically. Say if the regression is recent one, there is no recut required. So as such, you can relift the flap. And if you ask me, my choice of treatment will be always doing a LASIK, means relift the flap and do the laser instead of doing a surface ablation in those cases. And like Dr. Hosam said, you come across cases where the patient has undergone LASIK 6-8 years before, and you get those flap thickness of 160 or. But in those cases, I would prefer doing a recut with microkeratome instead of going with femto. And of course, the diameter should be a larger one instead of choosing a shorter diameter. I have operated few cases where I couldn't relift the flap. Those were 8-10 years old. In those cases, yes, I have taken a larger diameter with 100 micron flap. And if you take a flap with microkeratome in such cases, it's very easy to take a superficial flap, and you need not touch the base of the previous flap also. So I think that helps.
Yeah. Okay. Okay,
Thank
sir.
you.
But Dr. Rajesh, can I?
Yeah, please.
Okay, can I comment? Okay, Dr. Darak, I'm with you, but Dio, in such case, when you get a new flap with a microkeratome, are you sure that you will lift the new flap itself alone?
That is pretty easy.
I have lifted an older flap after 14 years from LASIK. I think there is no problem to lift the flap at any time.
Yeah. Many a times when the contrast, particularly light colored eyes, where you cannot see the contrast, it's difficult to relift that flap. In that case, this recut with microkeratome helps, because when you apply the femto energy, you have to struggle with that flap separation and everything. And there is a possibility you relift the older flap or previous flap. But like if you take a microkeratome cut, then probably you can relift that, means you can lift that new flap very easily, leaving that previous thing behind.
Okay. Okay. Thank you.
Absolutely. So now we move on to the next speaker, and that is Dr. Ritika Sachdev, who will be talking about post-LASIK ectasia. Dr. Ritika Sachdev.
Is my screen visible?
Yes, it is.
Good evening to all. I'd like to start by thanking Dr. Tityal, Dr. Namrata, and Dr. Rajesh Sinha for really laying the foundation of cornea and refractive surgery in my life. And I'd like to thank Dr. Rishi Mohan, Dr. Mukherjee for also inviting me to this panel. I'd be talking about decoding the enigma, which is post-LASIK ectasia. Post-LASIK ectasia is the most dreadful but fortunately rare complication that a refractive surgeon has to face. In fact, this complication is very important because when a survey was done in the Americas, the reason for most surgeons to be not opting for refractive surgery was fear of ectasia. So ectasia, though uncommon, is not fully understood, and I'll just be sharing the literature about post-LASIK ectasia. The incidence of ectasia is reported to be 0.04 to 0.6%. It has been said that with the Schimflug devices and measurement of the posterior corneal curvature and proper screening, this risk has become halved. Do note that 96% of the ectasia has been reported following LASIK, because here you are compromising more of the anterior corneal strength, and only 4% following PRK. SMILE is, of course, the new kid on the block, and we still have to understand ectasia post-SMILE fully. 50% of the ectasia occurs within the first year itself, and 80% within the first 2 years. So you must follow up your post-LASIK and post-PRK patients for the first couple of years. We now have reports that post-PRK ectasia may have a later onset, and even post-PRK decade-old ectasia has been reported. What does an advanced ectasia look like on topography is similar to keratoconus. However, it is the early ectasia that you must not miss. This is the inferior steepening that is visible in cases of early post-LASIK ectasia. What is very important is that in your cases, do keep a serial topography map of all your patients. And like you see here, a serial topography map really clinches the diagnosis and also helps you detect progression in these post-LASIK ectasia cases. What really causes ectasia is not completely understood, and we have really a list of risk factors that predispose one to ectasia. The most important risk factor being abnormal topography, and topography abnormal to the extent of keratoconus, of course, is a contraindication for any refractive procedure. High myopia, young age are two other risk factors. Low residual stromal bed thickness is also a risk factor. There is no magic figure that is available, but Barkwer gave us a figure between 250 to 300 microns. That is the minimum residual stromal bed that we should aim for. Excessive ablation or a thick flap also reduces the tensile strength of the cornea and is also a risk factor. Late post-operative risk factors include eye rubbing and pregnancy. Now, when you want to really develop a scoring system, taking into account all the risk factors, there are various examples that are available. One commonly used scoring system, which became popular after 2005 because there was a multi-million-dollar lawsuit that the patient actually won because he had post-LASIK ectasia. And then there was a committee set out, and then Randleman came up with this scoring system, wherein if the topography is abnormal, the residual stromal bed is thinner, the patient is younger, the central corneal thickness is less, and you're correcting higher myopia, you add the risks, and a risk of more than 4 points is a high risk patient. Do note that these scoring systems have had a sensitivity which has been reported higher by the authors and sometimes is not shared by other people using the scoring system. The Randleman scoring system is supposed to have sensitivity and specificity of more than 90%. Another system which was another factor that was introduced was by Santiago et al. which said that you look at the percentage of tissue altered, because when you create a LASIK flap, that flap is functionally decoupled from the cornea, even if you reposit it. So the flap plus the amount of cornea that you ablate is the loss of the tissue. That means you've altered that much tissue. So the flap thickness plus ablation depth divided by central corneal thickness will give you the percentage of tissue altered. What is important to note is that percentage of tissue altered more than 40% means that you have a patient who may be at higher risk of ectasia, again with a sensitivity and specificity more than 90% as by the authors. However, with an abnormal topography, PTA is not valid. So if a patient has abnormal topography and you're still taking him up with a lower amount of ablation, he may still develop ectasia. So abnormal topography must be ruled out. Do note that the Randleman scoring system did not take into account the posterior corneal curvature. And as the diagnostics have improved, we now have more and more factors that are coming into play. So topography with the posterior corneal curvature mapped is really very important. These are some of the factors that you must rule out in patients you're taking up. What is a newer development is that you have to assess the epithelium. In areas of ectasia, if the epithelium is thinner, that ectasia may be masked. Epithelium is now being studied as a masking agent, that uneven thickness of the epithelium can mask the irregularities of the cornea. So even if you do a complete topography of the corneal surface, we must measure the epithelium in isolation and see if there are marked variation in epithelium thickness that are masking an underlying ectatic zone. Irrespective of what we do, we still cannot fully predict post-LASIK ectasia. This was a patient of ours which developed unilateral corneal ectasia 6 months after an uneventful smile and a normal pre-op topography. So really, why cannot we fully understand and predict ectasia? This is a paper by Dr. Cynthia Roberts, which tries very well to explain why this is so. What causes ectasia is molecular, genetic, and environmental. And the bridge to that is the biomechanics, and topography is the manifestation. So when you are just studying the manifestation, you cannot predict or control the disease. Hence, our understanding is limited. Biomechanics is possibly a way to enhance our understanding, but it is not giving us enough. Why is that so? Is because we are measuring the gross biomechanics of the cornea. When we measure the gross biomechanics, there is a very significant overlap between a normal and a keratoconic cornea. This paper by Dr. Cynthia again points that post-LASIK ectasia really starts as a localized area of corneal weakening. This is a biomechanically weaker area which has a lower elastic modulus. In response to that, it thins out. And the response of a thinner cornea to stress distribution is that it becomes steeper. So this will cause an ectatic zone. Note that this is a focal change, and when you're measuring gross biomechanics, you will not be able to distinguish this weakness from a normal cornea. So therefore, biomechanics, though is a starting point, it hasn't led us to a conclusion. So though we have various risk factors that we are assessing to eliminate the risk of ectasia, and we know that we cannot fully eliminate it, what do we do when it does happen? We strengthen the biomechanics with the only technique that we know how, which is of doing corneal cross-linking. Visual rehabilitation in the form of RJP is successful in nearly 80% of the cases. In our practice, we use ICRS, and we feel it is a great adjunct in treating cases of post-LASIK ectasia. Topo-guided PRK may also be done. Advanced cases, however, need to be taken up for a corneal transplant. Corneal cross-linking can be done with the traditional epithelium off. However, there are people who are recommending trans-epithelial approach to cross-linking, and also authors who are recommending lifting the flap, putting in the riboflavin with NaCl, not with dextran, into the flap interface, washing, and then doing a trans-epithelial cross-linking with the riboflavin, which has been embedded into the stroma through the interface. However, do note that cross-linking response in post-LASIK ectasia may not be as robust as it is there in keratoconus, because possibly the pathophysiological differences play up, and also the cross-linking of the flap may not contribute as significantly to strengthening the cornea post-op. This is where I feel intacts or intracorneal ring segments have a very important role to play. This topic will be covered as in the future talks, but I'll just be showcasing one patient. Now, this was a question that has also shown up in the chat. Pregnancy is a great risk factor for ectasia. In pregnancy, estrogen levels are more than 30,000 times higher. And estrogen receptors are known to upregulate the collagenase activity through prostaglandin release. So this really predisposes a cornea to ectasia. This is a patient operated for LASIK elsewhere, came to us with post-LASIK ectasia during her first pregnancy. Remember, serial maps are important. You see here, obviously, this is a progressive case and we've cross-linked her. Despite cross-linking, this is her position in her second pregnancy. There is a continued progression of the ectasia. This is her other eye. She presented with more advanced ectasia in this eye. And we did a cross-linking plus intracorneal ring segments in this patient. And during her second pregnancy, she maintained a stable corneal topography and refraction and visual acuity. This really points to the fact that the intracorneal ring segments not only bring about visual rehabilitation. Remember the paper by Dr. Cynthia, this is what they do. They redistribute the stress forces and possibly break the vicious circle of ectasia that has set in. Now, there are newer modalities that are also being studied, though collagen cross-linking and ICRS remain the main modalities. We now have additive tissue techniques such as insertion of lenticules or tissue, sometimes in the interface, and a cross-linking that have been reported. So with all these modalities, we are aiming to not only make the ectatic cornea biomechanically stronger, but also give visual rehabilitation to the patient who has come to us seeking better vision without glasses. So all in all, I think ectasia is summarized by the more you think you know, the less you know, the more you know that you do not know. So thank you all for your attention.
Thank you, Dr. Ritika. And it was a wonderful talk. Dr. Tityal, sir, you have loads of experience handling these post-LASIK ectasias. Can we have a comment from your side, please?
I think Dr. Ritika, nicely presented the entire scenario. And we know that incidence of ectasia happening after laser refractive procedure is very, very less. But once it happens, the visual outcomes is so poor despite managing these cases appropriately. I think one of the major challenges for us is to give them back the vision they would have had immediately after surgery, which is I think biggest challenge with us. And especially, even after cross-linking, what Ritika was talking about, many patients may still have a progression after cross-linking also. And maybe, I have not done personally many cases with intracorneal ring segments in these cases. Maybe combining that with cross-linking may be helpful in these cases of post-LASIK ectasia. And the major experience with us is using contact lenses for these patients. Especially, we have now trying ortho-K devices for these patients to decrease the progression, and some patients are doing wonderfully well with ortho-K practice now. I think that is one area we have to look into.
Thank you, sir. And Dr. Leonardo has to leave actually, so he has requested for an early presentation, and since he will be talking about the intracorneal ring segments, so can we have his presentation on complications with ICRS? Dr. Leonardo Torquetti.
Good evening, everyone. First of all, I'd like to thank to my good friend Rajesh for this kind invitation. I'm very happy to be with you this evening. And apologize, I have another webinar, and it has been a great webinar of the Indian Society of Keratorefractive Surgery, but I need to leave a little bit early. Well, I'll talk about complications with intracorneal corneal ring segments. And there are just a few publications about this theme. This is the largest sample of patients published about complications about after rings. And the complication rate in this paper was 6.5%. And regarding intraoperative complications, the most common, it was incomplete channel formation with the femtosecond laser. And about postoperative complications, the main complication was migration of the ring. We have a paper published some years ago. We evaluate 1,073 eyes, and the reoperation rate, meaning complication of 3.45%. So it's a reasonable rate of complications. And there are 4 main types of reoperations when we face complications: exchange because of over or under correction, removal in case of superficial segment and or overcorrection, addition in case of undercorrection, and repositioning in case of migration or wrong placement of the segment. The complications can be related to preoperative factors, can be related to intraoperative factors, and postoperative. About preoperative factors, a common complication is wrong selection of the patient. For example, very advanced cases or untreated atopic patients. Moreover, we can have wrong selection of segments. Here you see a case, a very advanced case, a patient that should go for a doll, not ring. It was planning to implant a segment. This patient had 72 diopters at the apex, and there was a perforation during the ring, during the tunnel for with the manual technique. So unfortunately for this case, it was not possible to go to a dog. This patient had a PK because of the failure of the endothelium. Another case, a wrong selection of patient in patients with vernal keratoconjunctivitis and treated and implanted with the rings. It's not uncommon for this patient to have new vascularization of the segments. In this case, you should treat this patient with topical corticosteroids, oral anti-allergic drugs, tacrolimus, and in case which we have new vessels inside the tunnel, we need to go with subconjunctival bevacizumab or intravascular bevacizumab. We can achieve this intravascular bevacizumab with a 34 gauge needle. Trying to go inside the vessel, we can have very good results with this procedure. About wrong selection of segments, this patient needs to be implanted with 2 segments. However, the thickest segment was implanted in the flatter area, and the thinnest segment in the most ectasic area. And this was the result, a huge flattening in the already flat area. And after removing the segment, we can achieve a much better aspect of the topography. Here, a case of a thick segment implanted in a thin cornea. You see here at the point of the incision, the cornea is thick, but it is very thin inferiorly. When you see at the slit lamp, we see almost no stroma overlying the segment. So there is a high risk of extrusion in this case. When you see the epithelium is completely irregular because of thick segment in a thin cornea. So in this case, the segment should be removed. And we should always follow this pachymetry's law that states that the thickest segment of a pair of segments cannot exceed half thickness of the cornea in its bed. So you should never implant thick segments in thin corneas. About intraoperative complications, it should be wrong centration, wrong axis marking, perforation, shallow pocket in case of manual technique, incomplete tunnel, asymmetric tunnel and segments, wrong ring placement, corneal abrasion, and perforation and wrong centration. In case of incomplete tunnel, it usually occur with the femtosecond laser. It's with the new laser, it's quite uncommon, but every surgeon that implant segments with the femtosecond laser should be trained with the use of the Maynard technique in case of incomplete tunnels. But it's quite easy to solve. It's just to enter with the spatula and to complete the tunnel. Here's a case of suction loss or vacuum loss with the femtosecond laser. This is quite uncommon. In this case, you should stop the procedure, observe, and to make a new procedure in 1 month. It's quite enough. Then the tunnel will be completely sealed, so you can proceed in 1 month. It's a case of ring in the anterior chamber. This segment was placed, and the surgeon just realized the segment in the anterior chamber in the following day. So it's quite uncommon as well, but the treatment here is viscoelastic in the anterior chamber, paracentesis, and then to take out the ring from the anterior chamber. This is a patient that a colleague called me and told me the patient has a persistent inflammation, some corneal edema, and I don't know why. This is a 320 segment. And in this case, obviously there is an obvious perforation. By doing anterior segment OCT, you can see here the perforation during the femtosecond laser, and it was not realized during the procedure. So in this case, you need to remove the segment, wait for healing, and then schedule a new procedure in 3 months in this case of perforation. Asymmetry of segments, it usually almost occur with the Maynard technique. You can see in some cases with the femto, but it's quite uncommon. In this case, you can just observe it. You can have good results despite of that, but in most cases, you should remove, retunnel, and exchange the segments. Here are some cases of extremely badly positioned rings. So in this case, you have to remove the segments to make a new tunnel and exchange the segments. Another case of wrong position of segments, here a very deeply implanted segment, a pre-descent segment. There are 2 problems here. We know that the rings are very safe for the endothelium, but in this case, it can be harmful for the endothelium. Moreover, it's not implanted into the stroma. It is pre-descent, so it lacks its effect of flattening. Here you see the specular microscopy showing some chains in the left side of the really deeply implanted segment, and you should remove the segments. But the problem here is very difficult to remove without disrupting the cement membrane in these cases. And postoperative complications, extrusion, infection, migration, and white deposits. Extrusion is it's much rarer today with the femtosecond laser than it was used to be in the past, but it still can occur in the initial learning curve, especially with the Maynard technique. And there are 3 main risk factors: a ring that is left near to the incision, a shallow tunnel, and a thick segment. And in all of these cases, you should remove the segment as soon as possible to avoid melting. And this melting could make difficult to implant a new segment in a second time. Infection is quite uncommon. You should consider the ring implantation as any surgical procedure of the surface. So you need to be careful with preoperative blepharitis. You should treat preoperatively. Moreover, when you take out the ring from the package, to avoid to let it touch to the conjunctiva, to the leads, because it can increase the risk of infection. And in all these cases, you can, in case of recent infections, mild infections, you can just use fortified antibiotics and observe. But if there was no response in 24 to 48 hours, or in case more advanced, you should take the ring out and treat more aggressively. Migration is not common. It occurs in case of incomplete tunnel, a white tunnel, usually with the manual technique or eye rubbing. In this case, on the left side, you see there are some white deposits around the tip of the ring. It is an epithelial ingrowth. So in this case, you should remove the segment, wash the tunnel, and implant a new segment. And periannular deposits, these white dots, usually in the inner face of the segments, are quite uncommon today. It was more common in case of the manual technique. It usually means white tunnel, but it's completely innocuous. You should just observe it. It is just a finding. It's not a real complication. In conclusion, the incidence of complications related to rings is low. In most cases, it's possible to attain good visual outcomes after complication management. And the ring implantation is a safe option for keratoconus treatment. Thank you.
Thank you, Dr. Leonardo. It was a wonderful coverage of all sorts of complications that one can have with the ring segments. We are running a little late, so we move on to the next speaker, and that is Dr. Sujata Das, who will be talking about post-LASIK keratitis.
Rajesh, can you see the slides?
No, you have to share it.
Not yet?
No.
Now?
Yes.
Can you see now?
It has not opened up. It was opening.
Yeah,
now it has opened up.
Okay. I'd like to thank ICRS, especially Professor Rajesh Sinha, to invite me. I was physically there in ICRS few years back. Okay, so I'll be describing on devastating complication. It may be rare. We may not see in our lifetime also. Nobody wants to see the eye LASIK refractive surgery like this. So basically, incidence, it is difficult to estimate. It varies. It may be from 0 to 1.5%. You can see this. So studies are all before, most of the studies are before Femtosecond. All these are 0 in spite of 1,000 cases. Culture positive infection is 0. So negative infection is 2. And price group has not a single case of gram positive or gram culture positive or negative keratitis. Basically, the risk factors can be divided into intraoperative, preoperative, and postoperative. In preoperative, blepharitis is most common risk factor we should rule out before we plan for surgery, followed by dry eye. Prior corneal surgery, we don't do many with prior corneal surgery. All this literature is basically for radial keratotomy, which have undergone laser refractive surgery. And lack of perioperative antibiotic is another cause which can lead to post-LASIK keratitis. The most common one, I'll say maybe 99% responsible, is lack of aseptic technique. And again, in aseptic technique, mostly people use blade many times. In between the eyes, there's no sterilization, multiple use of microkeratom blade. Epithelial defect may be intra-op or post-op. The trauma, then we put a contact lens, so it leads to another risk factor. And post-operative use of steroid is another risk factor. Trauma may happen again intra-op, which can lead to epithelial defect or post-op. Early onset is usually people divide within 1 week of surgery, and late onset is after 1 week of surgery. You see, most of the reports are within 1 week. However, all those are bacterial origin. All of those are from Western countries, which is acute cases is 62.5%. Here, acute within less than 7 days is 50%. Here also it is more than 50%. So most of the cases, the organism is Staphylococcus or Streptococcus. but not necessarily. Here, mycobacteria is there in 50% cases. Like other microbial keratitis, patient will present with the same clinical feature: pain, redness, photophobia, watering, and defective vision. This is a patient which is due to mycobacteria infection. It may not look like typical mycobacterial infection. The infection may be focal. If you see a single focus, it may be multifocal like satellite lesion, or it may be diffuse. It may present as an abscess or in a surface infection like an ulcer. It may involve only the flap, or it may restricted only to interface, or it may involve whole cornea like this: whole cornea, flap, deep stroma, and interface. So either it may be epithelial defect like this patient who there is no epithelial defect, is an intact epithelium, or there is a whole flap is necrosed here. This is acanthamoeba keratitis, and it presents like a typical acanthamoeba keratitis, but we are not lucky to have all classical clinical picture like a virgin cornea. It may differ. So it may present with a AC reaction. This is a case of fungal keratitis, long onset. You can see lot of vascularization and hypopyon. The main common differential diagnosis is diffuse lamellar keratitis. You need to have a high index of suspicion if you have operated the patient. How you differ between microbial keratitis and DLK? DLK onset is early in cases of few days, but microbial keratitis may be early or maybe within months, or of course maximum patients may be presented within few days. And DLK, the infiltrate are diffuse throughout the bed. The microbial keratitis mostly localized to start with a focal, it may progress to whole bed. And DLK usually respond to steroid, the eye is not congested, whereas in microbial keratitis, the eye is congested, and with steroid, it may worsen. So in early onset, most of the organisms are staphylococcus, sensitive early onset will not have a acanthamoeba, but usually the organisms which are chronic cause, they present late. Like mycobacteria is the most common, although it is an uncommon infection in corneal infection, but most commonly it presented with my LASIK cases. I'll say it is the most common organism. Similarly, nocardia, it is not very common in microbial keratitis, but in case of LASIK, it is a common organism. Fungus, in our country especially, we see fungus, filamentous fungus. However, from Western countries, we get report from Candida mostly. Acanthamoeba virus, I will not say due to sepsis, but there are reports of adenoviral keratitis and HSV. So these are the reports from various places about the culture positivity and culture gram positive and gram negative. If you see whole case series review, then mostly it will be gram positive organism. But however, there are fungus also, like for example, this is from LV Prasad Eye Institute, where you see 5 nocardia cases and 4 fungal cases compared to 2 gram positivity. The diagnosis, the first is clinical examination. And if it is an interface keratitis, there is no epithelial defect and we have access to confocal microscopy, we can use confocal microscopy. Corneal scraping is definitely required to have a definitive diagnosis. If it is ulcer, we can scrape the surface. If it is in the interface, restricted only to interface, we need to take the patient to OR and lift the flap and take the scraping from the stromal bed or backside of the flap. In addition to gram and KOH, which is routinely used for microbial keratitis, in cases of LASIK keratitis, because we see a lot of mycobacteria, we can plan for acid fast, 1 smear extra, or else microbiologists can do decolorize the gram stone and use acid fast 10 if you have a strong suspicion of mycobacteria and nocardia. If you are removing the flap, always send part of the flap to histopathology if you don't get anything from microbiology. Medical management can help in early cases if it is a small focal infiltrate. If it is restricted only to interface, flap lifting will definitely help. Wash the interface thoroughly with antibiotic. We may need to repeat the antibiotic wash. If it is completely necrosed flap, better to sacrifice the flap and, as I told, send to microbiology and histopathology rather than throwing it. if it is not responded by this treatment or is very severe, few people may need therapeutic keratoplasty. This is again from Vikas Mittal group. There's a 6 cases of 1 case is both eyes. Again, all are fungal keratitis. You can see most of the patient require combination therapy. Although routinely we don't prescribe voriconazole natamycin combination, we start with natamycin. But most of the patients in post-LASIK fungal keratitis, they needed both the antifungal drop. And most of them responded to medical management. Medical management means not therapeutic keratoplasty. They all of them went for flap amputation, but final visual outcome is between 22 to 28. This is again another series where all fungal infections, starting from Candida to Aspergillus as well as Fusarium. Few of the patient needed flap amputation and tissue adhesive. And visual acuity, as expected, fungal keratitis will have a poor vision compared to bacterial keratitis. As routinely we see for other microbial keratitis, the vision is for counting finger 2 meter to 20 by 20. So like Namrata told in epithelial ingrowth, prevention is better than management. You should rule out predisposing factor when we plan for surgery, especially blepharitis or dry eye. Proper eyelid hygiene has to be maintained before we do surgery. And the main important factor is strict adherence to SFCs during surgery. So I conclude my talk saying that incidence of post-LASIK keratitis is decreasing. This may be due to many factors, I'll say. One is femtosecond laser has come, surface ablation also has started, and maybe awareness, or the last factor, maybe we see a lot of literature in the past because LASIK was newly started, may not be published, but I assume the LASIK infection has gone down because of the other reasons. We need to have a high degree of suspicion, especially to rule out for diffuse lamellar keratitis. If somebody is complaining redness, pain, we should ask them to come early. Various etiological agents like bacteria, fungus, and parasite have been reported from post-LASIK keratitis. However, luckily, most infections respond to medical management unless they present LASE. Detailed microbiological workup will help in definitive diagnosis and appropriate treatment rather than treating empirically. Thank you.
Thank you, Dr. Sujata. It was a wonderful presentation. We have a few questions, but we will have it in the end. And we now move on to the next speaker, and that is Dr. Hossam Zaida, who will be talking about post-surface ablation haze. Dr. Hossam Zaida, please.
Thank you, Dr. Rajesh, for this kind invitation to this great meeting. It's my pleasure to be with all of you. I'm sharing my screen now. Okay. Can you see my screen?
Yeah.
Yes, we can see
Go
it.
ahead.
Thanks.
Okay. Good evening, everybody in India. Good afternoon in Egypt, and good morning in Brazil. So one of the nightmares of the surface ablation is the post-surface ablation haze. Surface ablation includes the PRK, which is the photorefractive keratectomy, the LASIK, which is with epithelial flap, and the epiLASIK epithelial flap in LASIK formed by the alcohol, and the epiLASIK by the blunt plastic keraton. So my talk will be concise, maybe be emphasizing the part of the haze, post-operative haze. What are the causes, and what's the mechanism of haze? The corneal haze is defined as the superficial, which is subepithelial, or the superficial part of the anterior stroma, which is dot opacification of the normally clear cornea following the ablative surface ablative procedures. And we can define the haze in one word, which is overhealing. It's the normal healing, but somewhat exaggerated mood. So the histologically and the histochemically, the haze on histological and the histochemical studying of the haze, they found that the part of the haze is composed of the collagen type 3 and type 4, the fibronectin, the laminin, and the proteoglycans. and a huge number or increased number of the spindle-shaped keratocytes. So there's no abnormal cells in the site of haze. They are the all normal contents in this part of cornea, but they are aggravated and muchly increased than the normal. So we have to differentiate first between the haze and the punctated epithelial erosion, because in the early stage of haze, especially in the first week after completion of the epithelial healing, we may be worried about if this is haze or just punctated epithelial erosion. So it's easy to differentiate by staining of the corneal surface by fluorescein stain. If positive staining, it's dry eye. If it's not staining, it's haze. So the haze is due to increased density of the keratocytes in the anterior stromal part, leading to increased cellular-based reflection of light or scattering of light with noisy halos and blurred night vision, especially the blurred night vision in front of the lights, the clear lights. The grading of the corneal haze is as follows. The grade 0, where is no haze, the 0.5 trace corneal haze. Grade 1, the mild corneal haze not affecting refraction. Grade 2, moderate corneal haze with difficult refraction. Grade 3, the corneal haze preventing refraction, but anterior chamber is still visible. And the grade 4, which is the most severe form of haze, where there is a severe corneal opacity, preventing both refraction and completely obscuring the iris details. Causes are actually the predisposing factors of haze. What they are trying to understand, the factors which may lead to haze, to avoid it or correct it. I think the first one to talk about the mode of epithelial removal. We have 3 modes to remove the epithelium in the surface ablation, especially the PRK I'm talking about: mechanical debridement using the Hockey knife, and the alcohol-assisted epithelial removal using just 18 to 20% ethylene alcohol to delaminate the epithelium, not more than this concentration, not to be highly toxic to the epithelial cells. And finally, the trans-PRK using the laser itself, like the mode or like the program of the PTK to remove the epithelium first and then correct the error on the remaining surface with the PRK program. So the trans-PRK is 2-in-1. What are the what's the mode which is less causing haze or helping to get a haze after surgery? The mechanical debridement is somewhat traumatizing. It's minor repeated trauma to the corneal surface, so I think it will enhance and trigger the inflammatory response, and it will increase the haze because it's a tough method. The alcoholic removal or the alcohol-assisted removal of the epithelium will be lesser than the mechanical debridement, but still having the risk of the toxicity of the alcohol toxicity to the epithelial cells and to the surface of the cornea, so you will get some haze after. The last method is the trans-PRK, which is smoother, more gentle, and more planned to remove the epithelium with a good transition at the peripheral part of the epithelium removed. So it's the last one to get a haze after. The incidence in a study with the trans-PRK was 4%, with alcohol was 6%, and with the mechanical debridement, it was the highest, with about 3-folds to the laser removal. It was 14%. So it's much helpful to use the laser to remove the epithelium than the others, and the alcohol than the mechanical debridement. Also, the second factor could be the ablation depth and the amount of error. The ablation is performed at the Bowman's layer, put it in the mind. The Bowman's layer, it's a homogeneous layer of the anterior stroma, containing the collagen, certain type of collagen. So it's not like the other parts of the cornea. When damaged, it doesn't regenerate. So it's replaced by the scar tissue, and it is the aim of it's the core of the mechanism of the haze. Ablation is performed at the level of the Bowman's layer and the anterior stroma, which is the site of the fibroblast activity. From this point, I can say that the amount of error or the ablation depth is not a matter. It's not different, in my opinion, based on this point, because when you go to correct more amount of error, you will go deeply in the stroma, but you passed on or you ablated the Bowman's layer and the anterior stroma, which is the site of the fibroblastic activity and the formation of haze. So the depth, the ablation depth, when increases, it will affect the biomechanics more than getting haze. So the recommended residual stromal bed after BRK is 400 microns. It is D2, it's related to the biomechanical issue, not to the haze itself. So ablation to correct small errors could cause significant haze. I cannot forget a case of just -1.5 diopter myopia when ablated by the surface ablation for something suspicious in the anterior sagittal curvature. But in such case, the error was very small amount, so I didn't use the mitomycin C in this case, and I found severe haze, which was intractable and took a very long time to heal. Also, the flying spot is with much lesser incidence for haze than the broad beam. Other factor is the temperature. Regarding the corneal temperature itself during the procedure and the room temperature of the operative theater, and also the geographical temperature and the humidity of the country. The corneal temperature is muchly affecting the haze incidence. So it's recommended to cool the cornea all the time and to rehydrate the cornea. If the cornea is quite dry during the ablation, please stop the laser ablation and rehydrate the cornea again to decrease the haze, because the temperature is an initiative factor, a physical factor to the healing process and the inflammatory reaction within the cornea. And the room temperature, it's query, it's not, there's no clear review about that, but all studies show that the room temperature is with very less impact on the incidence of the haze, but they tend to say that the room temperature could be cooled. And I think the room temperature in the operative theater for the refractive surgery is almost cool for the gaseous state of the device itself. About the geographical temperature, the point to talk about is the ultraviolet exposure. So the sunny and very hot countries, the population there are with more incidence for getting the haze if they are not stay indoor for a time and getting a good room temperature inside their houses. Also, the wearing of the polarizing sunglasses is very crucial to decrease the incidence of haze. The most important issue is the intraoperative prophylaxis, how to avoid the haze. By two things to do during the PRK, the chilled and the cold BSS. When you remove the epithelium, please wash your cornea with a chilled or ice cold, balanced salt solution. And also after application of the mitomycin C, wash it by 10 milliliter of cold PSS. It will decrease the incidence of haze as shown in this graph. The most important thing to do intraoperatively to decrease the haze is the mitomycin C 0.02% application for 30 seconds. The O reviews stated that the use, the time of application of the mitomycin is between 20 and 40 seconds, but I usually use it with this concentration for 30 seconds in all cases. There's no PRK now without mitomycin, even in the -1 or less amount of error. So I have found in my own experience now that the haze is almost 0% after application of the mitomycin C in all cases of the PRK with adequate concentration and adequate time. Then what to do after surgery in the early post-operative time to avoid the haze through the post-operative steroid. And the regimen which I follow is the post-operative steroid, prednisolone or fluorometholone, but I start usually with the prednisolone eye drops in this order. From the first day or from the hour 0, 3 hourly for 1 week, then 5 hourly for 1 week in the second week, and then I shift from prednisolone to the fluorometholone, which with less impact or with less incidence of steroid-related side effects, for 6 hourly for 1 week, and then 8 hourly for 1 week, and 6 hourly for another 1 week. So the old time is 5 weeks after surgery to use the steroid from the first, immediately after surgery, prednisolone for 2 weeks and fluorometholone for the next 3 weeks. And for usual treatment regimen, please keep monitoring of the intraocular pressure all the time to avoid the rise of the intraocular pressure, which will decrease the results and will deceive you about the post-operative results. Treatment options in case of haze. If you get a haze, despite all these measures, you will follow these lines. The longer duration of steroid, you will increase the dose and increase the time for 3 to 4 months, even up to 12 months. Don't be hurry. I will add the hydrocortisone eye ointment 2%, 3 times per day for just 1 month. Mitomycin C application, but in this case, I will use it as 0.01% eye drops. But actually, I never used in my practice. I just read it in the reviews, but I never used it. The PTK with the PRK for haze and regression after 1 year, I have just done it just one time during the all years of my practice. The PTK to remove the resistant and intractable haze for the first line, the previous lines. I have done it with as a combined procedure. The PTK for just 25 to apply just 25 microns from the surface to remove the layer of haze, and then the PRK after to correct the error, which is calculated pre-operatively, including in the calculation the part of the PTK with the hyperopic shift of the PTK. Don't forget in treatment the dryness, and please follow the IOP and give antioxidants. I'm not sure that the antioxidants will be withdrawal, but it could help in such cases. And finally, the conclusion: the corneal subepithelial haze is the nightmare of surface ablation. So in my practice, almost no haze after intraoperative application of mitomycin C. In 100% of cases, and the chill PSS, steroid therapy after the surface ablation is so crucial. Please don't delay it, because I didn't find any delay in the epithelial healing when used the steroid immediately after surgery. But plan for the dose and the follow-up of your patient. Don't be hurried to interfere with haze, not before 1 year of treatment. And thank you very much.
Thank you, Dr. Sam. It was a nice presentation on haze after surface ablation. So we had LASIK, we had surface ablation, we had ring segment, and now we move on to smile, and we have complications on smile, and we have Professor Jeevan Titial, who will be talking about smile lenticule related complications. Professor Titial, please.
Yeah, thank you, Rajesh. I think you have organized this webinar wonderfully well, getting our international friends also. You rightly said SMILE is there for last now. Can you see my presentation,
Yes, sir.
Rajesh?
Yes, sir.
Since 2008, the first clinical case report came, and now it's more than a decade now. And many people who are shifted to SMILE, they do almost 100% cases of SMILE because its advantages. There are basic 3 steps of surgery. One is docking, that is basically selecting the appropriate patient and the interface size for a particular white-to-white diameter. Then femtosecond laser application to create the lenticule and extraction of lenticule in a proper manner in such cases. So basically, it is a minimally invasive and innovative procedure where we make a intracorneal refractive lenticule, which is extracted through a small incision as such. So if you see this represented diagram here, first the laser will make a lenticule and lenticule side cut, then makes a flap and flap side cut. Through this small incision, the lenticule is extracted out. Just to show a small video how actually the laser application is done in these cases. You can see after we dock the patient appropriately, then you can see a laser application. First, it will create the lenticule. The laser runs from outside in. You can see the laser spot going and makes the entire lenticule and a lenticule cut. Subsequently, laser will do the flap cut. It will be in to out, and towards the end, it will make a side cut. So this is how it is laser applied. It is very small, you can say, a procedure in terms of time wise, and the application laser is very, very fast and effective. It takes less than 30 seconds to create. You can see 2 areas. One is the cap cut, one is the lenticule cut, and that is clearly appreciable under the microscope here. If you do a little bit of taking out bubbles there, you can see the clear margins, that is cap cut and lenticule cut is very easily demarcated. I think the major challenge for all spinal surgeons or beginners is basically to identify the edge. That is for anterior dissection and a posterior dissection in these cases. If you've done a 4 mm incision, first we do a left-hand side if you're a right-hand surgeon to create the anterior space for a dissection. Then you can see in a higher magnification also, you can see the instrument will be widely visible because the lenticule is underneath this instrument. And towards the other side, we'll do a posterior dissection, that is right hand side. You can see the posterior dissection being done. And you can see the edge is sharper than the instrument. So that tells you that you are in the posterior plane. So once you have proper dissection, the subsequent dissection can be done easily. So this is going posteriorly. You can see I've done anterior dissection, then going to posteriorly, release the entire addition all around 360 degrees, and lenticule can be taken out very easily. So you can see this requires a little bit of experience. And if you see, this is our publication where we did a review article on techniques of SMILE, which is open access journal clinical ophthalmology. And you can see the various techniques to extract the lenticule can be read out in that particular article. So it has various ways to, first you can do a posterior dissection, then take out the entire lenticule, that is swing technique, or you can do a continuous culvinator lenticular rhexis technique, like you do a rhexis in these cases after dissecting the anterior plane. Then you can do a lenticular techniques, you can do a irrigation, or you can do a hydroexpression or a push-up techniques. There are multiple techniques that they do have their own advantages and limitations. The surgeon has to pick up the right dissection technique so that they can improve their 100% results for getting appropriate plane for your patients. There's a learning curve. This is our learning curve publication of Cornea journal, which has various things right from the suction loss to a cap side cut here can happen in the learning phase. As you cross more than 50 cases, that is 100 eyes, your incidence of difficulty goes down significantly. So coming back to a lenticule dissection, I think that is a major challenge faced by SMILE surgeons. There can be two ways to look into this. First, normally we do anterior dissection correctly, but there's sometimes we struggle to reach the posterior dissection in these patients, and you create a damage and difficult to take out the lenticule. Or inadvertently, you do a posterior dissection first, then you have to look for anterior dissection, which is very, very difficult if you don't understand the entire surgical aspect of these cases. So these difficult scenarios would going to increase the complication, that is retained lenticule or a partial lenticule retention. That will cause delayed visual recovery, cap tear, side cut tear, posterior stomal damage, epithelial defect, and ultimately causing irregular astigmatism, which can cause the poor outcome in these patients. Though incidence decreases as your experience of surgery goes on in more number of cases, the incidence can be as less as 1% in your cases. And I think the difficulty, if you have to understand to begin with, anterior segment OCT can really delineate the position of your lenticule, your dissection areas. Subsequently, you can do a better assessment for your patients. Or sometimes you can do a Sinskey hook assisted peeling of lenticule, which gives you a plane for your subsequent dissection. And that works out wonderfully well in most cases. And once you don't have the access to a proper dissection, you keep struggling and the edema in the flap comes up or cap comes up. In that scenario, you may postpone the surgery and reassess the case subsequently in these cases. So ultimately, all these problems are going to cause delayed visual recovery in your patients, and that can be a challenge. So this is one of the first cases I had in my learning curve where I took a help of anterior segment OCT, and there I could delineate the the lenticule is still attached. I had gone posterior dissection first. With repeated attempts, I had a posterior stomal damage. So that is very, very important to assess how effectively you can do subsequent management if you have a cap lenticular addition for your patients. If you see, I had gone for a reverse Sinskey here and made a little crescentic nudging of the flap, and this gives you a space for a subsequent dissection to go get the flap, then go anteriorly and dissect out the case in these cases. Just to show a small video of one of our case where we had a difficulty, you can see I'm doing the same release of bubbles. First, this is a 2 millimeter incision here. Try to go anterior dissection first, and subsequently do a posterior dissection in these cases. As I said, one of the most important thing in a smile dissection is to appreciate the correct dissection plane, both anterior and posteriorly. So I'm trying to do a right side and left side for different area. This is a spoon-shaped dissector. So trying to do an anterior dissection first. You can see right from the first we do a central dissection, then go to peripheral dissection. And the visual axis dissection has to be clear and smooth for all cases so that you don't have difficulty in a post-op rehabilitation here. So I'm struggling to go to posteriorly. So what mistake I had done in this patient is to not being careful in initial dissection in this patient. If you see here, I'll go back again to show what difficulty I had in this particular case. To see initial dissection here, just observe here, I had already created a flap here that had gone posteriorly to begin with. So my entire dissection are posteriorly. So how should we manage this patient again here? We'll go with a sharp instrument here, nudge out the lenticule edge. So once I have nudged out the lenticule edge, getting little dissection, go anterior to this and dissect out the entire anterior area. So this is a simplified manner of knowing the edge profile and subsequently dissecting appropriately. You can see the entire lenticule comes out very, very easily. In fact, you don't have to use any forceps. The entire thing can be taken out in a bolus. And this shows that if you understand the right plane, the complication can be very, very less in a difficult scenario also. This is one of similar cases where I had again gone posteriorly to begin with initial dissection. You can see here, I'm trying to go posteriorly. This will cause posterior damage to the stoma. So you should do a minimal search for this. Instead of that, try to make a flap with the reverse Sinskey hook or a reverse side of this spatula, which is sharper one, that can give you access to the plane orientation. You can see I'm struggling here. So I'll just try to make the nudging of an area here. So once I nudge it out, I have this flap now. I'll go anterior to this. Once you lift this flap backwards, so you know that you have a flap, and subsequently the flap can be taken away. And once you have a smaller attachment left here, that can be peeled off with the forceps like a rexis and takes out. The most important thing here is make sure you examine your lenticule of its completeness. Otherwise, you may have a retained lenticule in some cases in this. The proper dissection, the outcome is quite good in these cases without compromising the post-op outcome for these patients also. So this is what we described meniscus sign in our patients. As I said, once you dissect towards the left-hand side, anterior dissection, the ring will get abolished. That means you are anteriorly dissected, and the posterior dissection, the ring will be intact. And if you push this dissected by a little bit, you create a meniscus sign. So this is what you see here. This is anterior dissection, and this is a posterior dissection where you have a meniscus here. So once you have meniscus, you can go posteriorly and dissection becomes easier. So sometimes difficult situation, you can create two meniscus in a cap lenticular adhesions, one towards the right hand side, other one towards the left hand side, so that you can do this lenticular rexis carefully without causing damage to your side cut in these cases. So this is the algorithm we have described in the journal recently. So if you have a difficult lenticular dissection, so you have to just look for a lenticular edge. So once you see a lenticular edge, just you have to push the lenticular edge to create a crescentic meniscus shape. Once you have meniscus, things are very easy to dissect anterior posterior. But once you don't get a meniscus, then you have to nudge the underside of cap to look for a cap lenticular adhesion. If you can see the meniscus sign there, you can dissect out carefully. If you don't get a meniscus in these cases, the adhesion can be confirmed by antersegment OCT, and then again take the patient back that you know that where exactly is your lenticule in these cases. So this particular crescentic sign is very, very effective way to judge if you are dissection anterior or posterior in these cases. I know that there are challenges in learning of a smile, but you understand the proper dissection anterior or posterior, the complication rate subsequently goes down. All complication related to a cap or a side incision is relatively attached to the improper dissection for your cases. With the wet lab training, customized laser setting procedure for your machines, a proper case selection and doing more cases will definitely benefit your surgical aspects. And nothing better than seeing the videos or learning through the books. This is a book on a smile that will make things more simpler and easier for all of us. Thank you for your kind listening.
That was really wonderful, sir. I would just complete the sentence that nothing better than seeing you doing the smile surgery. And those were wonderful tips that you, told us regarding how to do lenticule dissection, which is the key in smile procedure. So we move on to the next speaker, and that is Dr. Chitra Ramamurthy, who will be presenting on interface-related problems in smile. Dr. Chitra Ramamurthy, please.
Good evening, one and all of you. My very special thanks to Dr. Rajesh, Namrata has left, especially to Professor Dr. Titial and Dr. Rishi Mohan and all of you. So as we are already running late, let me go on to my talk about interface challenges in smile. So essentially, what we have come to understand that smile definitely has a following, with a lot more people embracing this procedure in this last decade. But the fact that there's an interface means there could be some challenges here, and I'm going to bring out a few of these issues which could very rarely creep in smile. So the first one is an epithelial ingrowth in smile. So we are all aware that epithelial ingrowth is largely a LASIK flap complication, more so after retreatments, for retreatments when we lift a flap, and more so in a microkeratome flaps and less in hyperopes. The essential fact here is that there has to be an edge lift. And if there is an epithelial defect overlying and a flap edema, the epithelial cell can ingress. Again, if there is blood or debris in the interface, that could cause a flap lift. Or if the flap has been overhydrated, or there has been a trauma, or there's an underlying infiltrate in the interface, all of these could cause an edge lift and the epithelial cells can invade. So essentially, the epithelial ingrowth occurs in a primary procedure or post-op invasion of an epithelial cell growth because of a edge lift in the flap margin. So we also know the treatment methodology, which was beautifully discussed earlier, that if it is somewhere isolated in a corner, a peripheral location, and it's not extending, we just observe it. But if it is encroaching onto the visual axis and there is a tendency for an overlying stromal melt, we need to intervene. So now this was a patient who underwent an uneventful smile procedure and came back after 6 weeks with a visual disturbance, just a minus 0.5 diopter of myopia, but there was some central steepening on his topography. But when I saw him on a slit lamp, there was that small collection of epithelial nest a little off the visual axis. So then, this was a routine procedure. There was an easy lenticule separation and the incision size was just 3 millimeters. There was no, I don't remember roughing up the entry site either. These are the probabilities of seeding of epithelial cells. So then comes to the treatment modality. It was a little close to the visual axis and the patient was disturbed, but there was hardly any stromal melt. So then I decided that something so simple as basic as this, I would intervene. So then it was difficult to locate the incision because all so transparent and clear. And then I found that the epithelium was so stuck to the stroma, so it was very difficult to insinuate the spatula. So I decided that I would just about create a pocket, and with the other end of the spatula, debrided the undersurface of the cap at the stromal side to remove that collection of epithelial cell nest, and washed it off with 0.02% mitomycin and did a thorough irrigation. And the next day, there was just a nebular haze in that area. And finally, the patient did very well, a vision of 6.6 and the topography clear. So it seemed to make sense to intervene even in this small collection of epithelial cell nest. The other approaches could have been using isopropyl alcohol, or if it had been a larger collection of epithelial cell nest, I could have done a circle software and created a flap, lifted it so that there could have been a greater ease of removal of the epithelial cell nest. So this was one isolated event in our series. We also had one isolated event of DLK post-smile procedure. We all know that epithelial defect is there, then the incidence of DLK increases by a factor of 24%. There was only one study series which was quoted at that time. And we are all aware that if it's a femtosecond laser flaps, there's greater femtodisruption, there's more accumulation of gas bubbles, there could be an inflammatory response, there could be increased inflammation and probable DLK. But what we remember in SMILE is that it has a very low pulse energy setting, just 130 to 150 nanojoules. Again, in its SMILE, there's hardly any stromal bed exposure. The incision site is so small, there's barely any epithelial cell disruption. So the question of a DLK is so very uncommon. One report case series which I came across was a very thin lenticule, and there was probably a difficult dissection because greater accumulation of gas bubbles when you use a larger optic zone. And this was one case series, one DLK in our series of SMILE. The routine procedure, it was a routine SMILE procedure, but the patient came back the next day with an epithelial defect, giving history of traumatizing his eye. And there was a dense focal DLK in the interface area. So one was to just let it be, just place a BCL and leave it. But I somehow felt that the haze being significant, that it made sense to do an interface wash right then, place a BCL for the epithelium to heal, and of course, club it with topical steroids and lubricants. And believe me, the procedure was just nothing, just going back the very next day and opening up the incision and just giving an interface wash. That's all I did. But the next day, the cornea cleared like magic, and the patient had a vision of 6.6, and the epithelium had well healed. And it sort of made sense that I removed that nidus of inflammation which was there in the interface in this particular situation. This was a third case wherein there was a stromal infiltrate in the periphery with a clear zone from the limbus. The overlying epithelium was intact, and this stromal infiltrate, the semilunar area, was well beyond the optic zone or the cap limit. So we decided to start the patient on topical steroid drops and clubbed it with oral steroid because it was the healing was quite graded. And we did that basic battery of tests to rule out any collagen disorder. This was a second week picture which showed that there was a definite resolution, and by 2 months there was a complete resolution and there was hardly any scar. Now this was a case, a routine topography, and the patient had a very small refractive error of 1.5 diopters. So, but what I missed out was that I had to change the lenticule thickness. And by the time I realized that had not been done, it was just 10 millimeter was the lenticule minimal thickness, and the photo disruption had started, and the cap and the cut and the incision cut, everything was done. So I decided that it was a very thin lenticule. So I very gently created my pockets. There was a tough dissection because of that irregular OBL in that region. So I went on and did a very careful separation of the lenticule from the overlying cap, ensuring that those area difficult dissection was very carefully dealt with because the lenticule was so thin. And then I thought I'd removed it, but all that came out was just a thin sliver. So it was very clear that I had actually torn this thin lenticule. So then with a lot of trepidation, I went back and then nudged, and then I felt there was some resistance in that area. I could see a fold of lenticule, and I just went in and tore it like you would tear a rexus and then spread it out. And I thought, well, that bit was taken earlier and this bit was done and it's over. But lo behold, the next day, patient had severe myopic astigmatism, significant, and the topography gave its own telltale story. So I was back with the patient, opened up the incision, but I thought I had to inject tricort, and hopefully this was my first experience. I believe that the remnant of the lenticule would get stained. And yes, there was that horizontal strip which was there. It did appear that it must have been a lenticule. So I went along the margin and nudged it. And the way it started folding up, it was very clear that it was a lenticule in that region. So I very carefully went and separated it from the overlying cap and the underlying stroma and tore it out. And you could clearly see that it was a large chunk of lenticule which had got missed out. Next day, the cornea was quite clear. And if you look at the topography, as I'm going to show you, it was quite okay. And the patient had a plano 6.9 on the first day, but later went on to do well. This was another patient who had a routine smile done elsewhere, but you can see that he had a 636 vision in his right eye, and there was a very irregular topography, steep K and a flat K. And if you look at the anterior segment pachymetry, it was again irregular, and the anterior segment OCT gave us a believe that there was a remnant temporally, but best illumination was the retro illumination of the well-dilated pupil, which told us that there was a significant, some kind of irregularity or a haze in the nasal part. So we went back, opened up the incision, and decided to explore in that area. So what I went as close to the overlying cap, and because the laminin tend to get stuck to the cap, and tried to insinuate there, I felt that I could get my instrument going up, and I felt that there was some kind of a resistance there. So I went on in that region, but it's still at this point of time, I was not able to identify the edge of the flap. When I went back with my instrument and tried to nudge it, and there I could see that edge folding up. So probably had been on the right plane, and I pulled the remnant out and spread it out. It did seem to make sense that this, the way as I separated, I realized that it conformed to that nasal area wherein the K was steep, and the anterior segment OCT had also said use a slit view to see there was no remnant. The vision was 6.6, and the topography had dramatically cleared up. So the message in this brief presentation of mine was, in SMILE, epithelial ingrowth is practically rare. All you need to be careful about is that you do not end up disrupting the incision site. Do not create thin flaps which could rarely buttonhole, and that could become a nidus for an epithelial cell ingrowth. Again, DLK can be very imminent, easily avoided. You need to ensure that the dock is gentle. You need to avoid dark spots. You need to optimize the energy setting if 2 or 3 cases you are having a dense OBL. Most importantly, avoid thin lenticule and avoid yourself to get into a situation where the dissection is more difficult. In these, if such things happen, DLK is practically non-existent in SMILE. Very rarely you could have a lenticule remnant, and it's important that you spread out the lenticule after you removed it in your initial cases to know that you have removed it in toto, because if there it's a little bit is torn, you can always go back in a primary sitting and get it out. But the occurrence of a lenticle remnant is so rare once your learning curve is over, and we need to adopt the right techniques of removal. I would like to conclude stating that each of these interface challenges, which I had shown you all, are imminently avoidable events. And all those negatives which we saw in our earlier cases in the femtoflap or the microflaps are completely obviated in SMILE. And I strongly believe that SMILE is the way to go in good number of cases. Thank you. I think I was quite brief, Rajesh.
Yeah, absolutely. Very crisp and very nice presentation, Dr. Chitra. And we just move on to the last topic, which is mine. And I'll be talking about one issue which is always coming up as far as ICL is concerned, because most of the issues of ICL have been sorted out. And it is the sizing that is something which is an issue which results in unacceptable vault. So the normal vault after ICL implantation, that is the distance between the ICL and the crystalline lens, is 250 to 750 microns. And with the current generation V4C model with a central aqua port, even up to 200 or up to 1000 microns is acceptable, because the risk of cataract or glaucoma is less with those vaults. However, if the vault is too less or too high, less than 200 or more than 1000, it is definitely not acceptable. Why? Because if the vault is too low, you can cause cataract, and also you can cause uveitis, because iris tissue is a large surface area of iris tissue is in contact with the ICL, and it keeps causing rubbing of ICL, and that can cause iritis. And if the vault is too high, then even with the current generation ICLs, you can have a very shallow peripheral anterior chamber, can cause PAS and can cause high intraocular pressure. So why do we have this vault surprise that is, after so much of improvement in technology? It is basically because we calculate the size of the ICL based on white to white, and the white to white correlation to sulcus is not very, very accurate. And we know that the sulcus is on average 0.42 millimeter longer than white to white measurement in a particular axis. However, there is a lot of variability as far as the relationship of white to white and sulcus dimension is concerned, and the ICL is placed in the sulcus. So if the vault is too low, then you have to, in any case, you have to explant the ICL and replace with one size bigger, because the vault, as we all know, that it decreases with time. But if the vault is high, something around 1000 to 1200, and if it's a toric ICL, then you can wait for some time, maybe a couple of months, because sometimes the vault settles, and then you can just carry on with the same ICL. But if the vault does not reduce, then you have to replace with one size smaller. But if it's a spherical one and something around 1200 or 1300, you can rotate the ICL and bring the long axis of the ICL into the vertical position. Now, this is an ICL wherein you can see the vault is too high. It is 1300 microns in this case. So, and the long axis is in horizontal meridian, and this ICL is a spherical one. So I have planned to rotate the ICL. Now, for rotating the ICL, there are two things that are very important. One is a nice dilatation of pupil, and the second is you should inject viscoelastic at the edge of the ICL here and here, so that there is a cushion of viscoelastic that goes between the crystalline lens and the ICL. Why? Because while you are rotating, you will rub the capsule of the lens as well as the zonules. So if you have a nice cushion of viscoelastic in between the crystalline lens and the ICL, then while rotation, you will not damage the zonules and you will not damage the crystalline lens. And once you have rotated it and made it vertical, then the viscoelastic can be aspirated out. Now, this is one case wherein the pre-op was 1300 microns and the post-op vault reduced to 700 microns just by rotation. We did a study in which we evaluated repeatability in white-to-white measurement in comparison with sulcus diameter for assessment of ICL size. We used OpScan 2, iTrace, LensStar, IOL Master, and digital calipers. And at that time, it was 2.5 years back that we did. We were calculating the ICL size based on OpScan values, but digital calipers also we were doing very frequently. And also did the sulcus to sulcus diameter by UBM. It is very essential to have a proper section while you're doing UBM. And for a proper section, the cornea, anterior and posterior lens capsule should be balanced over a theoretical vertical central line. I mean, the pupil and the lens capsule should be, you know, largely visible, and you can see the sulcus on both sides because you place the cursor manually here. So even if you know, if there is slight tilt, then the sulcus diameter will be incorrect. We found out that the repeatability of white-to-white measurement was best with IOL master. And since we were calculating the size of ICL based on OpScan values, so I just wanted to see whether we can use any other instruments or not. So we found out that there was a difference of 0.364 in white-to-white measurement between IOL master and OpScan. So we just thought that we just recommended that if we can do a correction factor, if somebody doesn't have an OpScan at that time, then IOL master can also be used. So you can use other instruments as well with correction factor and get a proper value. We did the sulcus diameter and also calculated the ICL size based on that. And just giving you one example that the white-to-white was 12.38 in one eye. The ICL size that we used was 13.2, and we found out that the post-op vault was 1.4. Now we went back and saw what was the sulcus diameter on UBM, and we found out that it was 12.3. So the size which was next to the sulcus diameter was 12.6, and this would have been more appropriate size of ICL. So if we had taken 12.6 instead of 13.2, the vault would have been much lesser than 1.4, something around maybe 700, 750 microns. So this is what this is something which we evaluated, and we found out that in 80% of eyes, the ICL size was correct with OpScan, but using UBM STS, we found out that additionally 7% cases we would have corrected the ICL size if we had incorporated UBM in that. So this study concluded that it's better to incorporate UBM as well as anterior chamber depth and white-to-white in order to get the appropriate sizing of ICL. However, there is one word of caution that when you are doing a sulcus diameter with UBM, you should be very careful in having a proper section so that you don't have an error in measurement of the sulcus diameter. So this is one issue that is still there as far as ICL is concerned. We do get some surprises, although it's extremely rare now when we have to explant the ICL because of this. However, it is still not 100% foolproof method, and I guess maybe once we incorporate the sulcus diameter along with the white-to-white and AC depth, we may be able to reach a level wherein the sizing of ICL can be, most appropriate. Thank you very much.
Fantastic talk, Rajesh. Question straight away. How do you evaluate the pentacam to do your white-to-white, and if there are any correction factors for that?
I'll just check. I don't remember exactly. It's something we actually calculated IOL master because IOL master had the best repeatability. So we thought that IOL master can be a substitute to OpScan. And in that, we had the correction factor of 0.364. Although even with other values like pentacam and lens star also, we had a correction factor. But since the repeatability was best with the IOL master, we concluded in the study that we can use IOL master in place of that with a correction factor of 0.364.
Great. Dr. Titial, there's a question for you from Dr. Ashish Bansal. What do you see as a difference between patients who undergo SMILE versus Femtosecond? And he also wants to know what are the refractive errors and cylindrical powers you treat with SMILE?
I think I had answered to him, to his question, but for other people, I'd like to answer this also. As far as refractive corrections are concerned, there's no difference between SMILE or LASIK patients. The indications, the workup, the criteria are almost similar, except for hyperopic correction, which cannot be done in SMILE just now, which will be a future trends. But as far as we are concerned, you can do up to 10 diopters now with the European CE approval for myopia. And I've gone as less as 1 diopter even of myopia also. There's no limitation as such. And whatever results we have now seen, we have just compared femtosecond LASIK with SMILE 1-year result, which is just going to be published very soon. As far as visual acuity is concerned, they are almost similar. But if you go to a quality of vision that is looking for a higher order aberration and other things, SMILE does better in terms of these at 6 months to 1 year. And the ocular surface stability was much better with a SMILE at 3 months, 6 months, 1 year compared to your LASIK patients. So there is a definite advantage SMILE for all refractive corrections in terms of longevity of whatever results you achieve for these patients.
Fantastic, sir. Dr. Ritika, your presentation was fantastic about post-LASIK ectasia. There's a question somebody in the audience wants to know that how many times and what will be your frequency of repeating your corneal topographies after you have done a ablative refractive procedure on a patient?
So we normally repeat a topography at 1 month, 3 months, 6 months, 1 year. If a patient is out of station, then it can be 1 month, 6 months, 1 year.
I'd just like to add one thing. I mean, is there anything specific you want to sensitize the participants on what to look for on topography?
There are basically post-operatively, I do counsel my patients about eye rubbing and pregnancy. We normally take the patient for visual acuity. Obviously, we call them for visual acuity. Even if a patient feels that the visual acuity is good, sometimes you miss an area of inferior steepening. And serial topography actually helps you when you develop ectasia even later. You have to have a pre-topography. So it's not that topography will be useful, but when you develop ectasia later, the previous topography helps you assess the progression scan. So we basically don't know when we need the previous scans. And also sometimes patients regress. And when a patient is regressing, also topography and epithelial thickness are important parameters to assess stability. And you know that if you're not only looking for ectasia, you're looking for regression and stability. That is the reason you should do topography.
Wonderful. Two things, if I may add, Dr. Ritika, is that, you know, most of these corneas are pretty flat after we have done a ablative refractive surgery. So not everybody as a general ophthalmologist is sensitized towards picking up post-LASIK ectasia early because they would expect the cornea to be very steep as such if you're calling it an ectasia. Yeah. So even if your cornea is flat, you should always keep a clinical suspicion of having a post-LASIK ectasia. As Dr. Ritika said, if your vision is poor, patient is not really improving, not getting a good quality of vision, and you obviously have your old topographies to compare. But another thing that I'd like to say here as an add-on is that analysis of the posterior surface is the most important thing in post-LASIK ectasia, because never go and check the anterior corneal surface topography. Even in your pentacams, ignore them. Ignore your art values, art max values, ignore your all your indices. Your biggest thing to see on a Bellin-Ambrosio would be a posterior surface elevation, because that is where the ectasia will start. And if you're delayed in diagnosing it, it will manifest as an anterior ectasia.
Absolutely. Long back, we had presented, we had some, we had a paper, Professor Titial knows that we had, together we had published a paper on post-LASIK ectasia, and it was posterior LASIK ectasia, posterior surface ectasia that we had presented. So that's very well said.
Yeah. Dr. Anant, there was a question regarding any drugs that can cause or prevent regression?
No, as such, there are no drugs which can induce regression. Only thing, we should be aware of the drugs which can bring about spurious myopia. We should not go ahead and treat the patient. So that is important.
So I'll like to know from you and Dr. Ritika as well, if you have a patient who is whose corneas are thin, who has a family history of keratoconus, and maybe her sibling has had a keratoconus which is not that doing that well, and that lady wants to have a pregnancy, maybe her second pregnancy now, what would you do? What would you advise her? Dr. Anand?
Yeah, I think we need to have the risk factor assessment all the time. Since we are doing very high volume, there have been situations where I have operated a patient 5-6 years back, who turned out to be normal, and now the patient, his brother or sister, has come with a history of keratoconus. Then it gives a shock to us. Then suddenly tell my brother is doing good, but he has developed keratoconus. And keratoconus genetic history almost less than 1%. I think if you assess history of allergy, family history, his refractive history for 3 to 4, if it's stable, I think we can still proceed. But provided explaining him that since you have a genetic trigger, we should be literally careful about it, and you may require a serial follow-up. Nothing wrong in doing it.
Dr. Ritika?
I also think that phakic IOL is underrated as an option. You have to think of phakic IOL and PRK extra. So for low myopia, possibly PRK extra, and for higher myopia, phakic IOL. So those are the two options. But I think also another option is no surgery, and the patient must first be counseled for no surgery. If there is an indication in social or financial or whatever reason that the patient wants, then only he should take up for PRK. So I really think as refractive surgeons, we don't keep no surgery as an option, and that has to be.
So how I would look at it, Ritika, see, it's a normal eye without a pathology, yes. and we are planning to do a surgery just for cosmetic reasons.
Yes.
So if we know technically in literature, in books, there is a high risk, high index of risk for this particular patient, I would rather counsel the patient and say that it's better to defer. Maybe we consider about 6 months or a year after your pregnancy. So what do you feel about that?
Actually, in practical terms, most of the people who get LASIK done are before marriage. So in the Indian context, it's very difficult to delay surgery practically. So if the patient has a family history of keratoconus, I would go for ICL or PRK extra if the patient insists on surgery.
Dr. Rishi, any comments on that?
I am a very conservative surgeon. So I think,
that's why I asked. That's why I asked you.
I would not touch that patient. I would spend a lot of time with this patient trying to make him understand what he's going in for and what kind of risks he's running. I am fundamentally also against essentially doing any procedure which thins the cornea when the cornea is already suspect or thin. And I just don't see the justification of doing extras and all that. I mean, for what? First, you thin the cornea and then to strengthen it. That too, without any specific reason to do so. To the extent of going in for lens-based technologies, I am with Ritika on that. In that, I would look at doing an ICL if the patient is very keen to get some form of refractive procedure done. But largely, I try to talk him out of it.
Makes sense. Dr. Chitra and Dr. Amrish, can you give us an account of what you feel on this situation?
Yeah, I would also, the strong family history, I would definitely not encourage the person to go in for it. And if maybe call them up for a serial follow-up at the most and tell them that if everything continues to be okay, we could consider a phakic ICL.
Dr. Amrish?
I think I'll follow up this patient for a year. I'll see for the topographic changes in this patient. And if everything seems to be okay, and if the PECI is permitting and there are no changes in PECI and topography map, I don't mind going for procedure in this patient. And
after some time?
After some time. At least wait for a year, follow up, at least have 2-3 topographies with you, see the progression. And probably if everything is okay, refraction is stable, then I won't mind doing surgery in this patient.
So the sense that I get is we all want to be a little cautious with these patients. Let's not be very aggressive with advising procedures for such patients. Coming back to post-LASIK epithelial ingrowths, we have seen a scraping of the epithelium, and that's very essential, as we know, to remove them. But how far do you go towards the limbus to scrape it? Would you just limit it to the edge of the flap, or would you like to go a bit ahead? Would you go away about 2 millimeters from the affected area that you're going to open up? Would you like to put a suture? What's the protocol, Dr. Chitra?
No. If I see an epithelial ingrowth, if it is something very small in the edge and the periphery, like rarely you have lifted, those days we used to lift flaps even 10-year-old and many years back. If you see a small along the margin, I would call them back and see that. If it's not increasing, I would let it go. But if I feel that tongue-like it is extending, even if it is away from the visual axis, I would not hesitate to lift the flap. Sometimes if it's just that local area, I would just lift it that area alone.
No, ma'am, the question was not what would you do in a case of epithelial ingrowth. the scraping of the epithelium on the surface of the cornea, be it on the flap as well as on the stromal bed, how far would or aggressive would you be in scraping of the epithelium before you lift the flap? Because the idea of asking this question is because it is the very same epithelial cells on the surface that can again go back into the tunnel and form an epithelial ingrowth.
It does make sense to scrape the epithelium a little beyond the flap.
How much?
Maybe just a bit. It also depends on the kind of epithelial growth. If it is gone really very much aggressive inside, then I would be quite aggressive to go about a little further beyond the flap margin. But if it's just a small extent, I would not disturb it too much at all. Because I have scraped epithelial ingrowths, and I've never had, excepting one situation where I had to discard the flap, I've never had a situation wherein I needed to get too aggressive about scraping far too much beyond the flap margin, just a little beyond it.
Dr. Hussain, what do you feel about this?
Yes, sir. About the amount of epithelial ingrowth itself.
No,
how much beyond the epithelial margin?
Question was if you are trying to remove epithelial ingrowth by scraping it off from the stroma as well as the posterior aspect of the flap, before you enter, would you like to scrape epithelium off the surface of the flap as well as the host cornea on the edge? Yes, the answer is obviously yes. But then how aggressive would you be about it? And how, to what extent would you do?
The extension of the epithelial removal of the flap from the surface of the flap itself? You mean that?
Surface as well as, would you go into the limb towards the limbus?
The back of the flap. Yeah, extension will depend about the extent of the epithelial ingrowth in the under the flap itself. I will remove the part included, especially at the edge of the epithelial ingrowth itself. The part of the flap. Usually, I'm removing the epithelium all over the lower half of the cornea, including the part of the epithelial ingrowth, and beyond.
So you'd like to be a little more aggressive than what you'd like.
Yes. Yeah, beyond the flap edge to regenerate from the start as it was a one line, helping prevention of the recurrence again. And I used to use a tip of a sponge with mitomycin C at the edge of the flap instead of suturing, but without wash, just touching the flap edge with the mitomycin C after that to decrease the incidence of migration of the epithelial cells inside again.
Dr. Sujata, what clinical dilemma
I just wanted to add one thing, Rajiv. I guess we just should take care of the edge. We shouldn't go too much beyond the edge in removing the epithelium. So we should just take care of the edge only and remove the epithelium completely from the undersurface and from the stromal surface. That is one. The second point I would like to emphasize here is that sometimes in the periphery you do have some clumps of epithelium. These patients should be regularly followed up. Actually, I have a patient who had epithelial ingrowth only in the periphery. It stayed in the periphery, but it started, getting thicker and thicker. And since it was in periphery, I was in two minds. And one day he came with melting of the flap, and that part melted completely. So I had to remove the flap completely. I did a sutureless anterior lamellar gradoplasty in that. I just measured the thickness of the flap on OCT and used a similar donor lenticule of the same thickness and removed that thing. So what I would like to emphasize here is that even if there is some epithelial ingrowth in the periphery, we should keep the patient on regular follow-up. Otherwise, if it clumps up and becomes thicker, there is risk of melting of the flap.
Fantastic.
Yeah. Okay. I want to add something to Rajesh. The aim of removing a part of the epithelium beyond the edge of the flap is the time which will be taken by the epithelium to regenerate again. If I remove the epithelium just at the flap edge, it will regenerate actually immediately within hours. Will creep over again. So if I remove the part of the epithelium away from the margin of the flap or the edge of the flap, it will take just 1 or 2 days to regenerate. During this time, the flap stocking and adhesion will be more, preventing the creeping of the epithelial cells inside again. This is the the purpose of removing part.
Thank you. Dr. Sujata, there's one thing that we commonly face as corneal surgeons is that when we get a referral for a post-LASIK issue, there's a big, and there's an infiltrate mid-stroma or in the stromal bed. There's a big diagnostic dilemma between DLK or if I may say a sterile infiltrate versus an infective infiltrate. And if it's a small one, you really don't want to scare the patient. You don't want to lift the flap. You may not want to lift the flap. So what is the protocol to A, go about handling these cases? B, when would you lift the flap and scrape? At what point in time? Clinical point of time.
Yeah, I think if it is a very small one, like normal microbial keratitis, 1 millimeter by 1 millimeter, people don't scrape, give empirical treatment. If it is early onset within...
No. Dr. Sujata, if I may. The essence of the question was to differentiate between microbial and non-microbial sterile inflammatory keratitis.
Okay. The first thing will be onset. Most of the DLK will be within 1 week. But for microbial keratitis, it may be 1 week or beyond 1 week. And microbial keratitis, mostly the infiltrate will be localized to one area, but DLK will progress with time. It may start in the one part, but gradually it will progress. The third one will be the eye will be congested and inflamed, mostly in the microbial keratitis. You see a lot of congestion, lead edema, like how we differentiate between sterile keratitis and microbial keratitis.
But then, Dr. Sujata, the problem comes in a case which is a 1 millimeter whitish spot, if I might call it. I'm not giving it a name microbial keratitis. How will you handle it? Would you call it infective? Would you put that on steroids thinking it's inflammatory component there?
If it is focal, I'll think better to have a high index of suspicion, thinking that infective rather than...
Exactly. So that was what I was looking for.
Yeah, if it is a small one, I'll not scrape, just start empirical. But if it is not responding, better to lift the plug.
Professor Titial, can you add on to that? I mean, your words of wisdom.
No, I think the point is well taken. I think both are rare nowadays. Both DLK as well as infectious keratitis post-LASIK is quite rare. And if we have seen many patients of post-LASIK infection, they come with a small infiltrate, which is like ICK type of picture. And in the time, within a week or so, it slowly will progress, because interface infections, sometimes they will progress very slowly. And you are in a doubt of it is a really infective or something else. So point is well taken. If infection has to be taken as a priority in terms of diagnosing these patients. And I think the most important thing is getting proper interface investigation. That means you may have to lift the flap as soon as possible in these cases. Don't wait for the infection to spread to a larger area. To swallow the area, lift the flap, take out the scraping, and go for identification of organism and start treatment for these patients. And we have seen more with microkeratoderm era now, and we can have a large series of patients coming from one particular institution sometime, because there was episodes also, because sometimes people use same blade for multiple patients and they do have infections. And very difficult to treat, we understand. And as soon as you think that this infection is going to go to the bed, that is the time you have to sometimes amputate the entire flap. That saves a day in cases. Rather than trying to save the flap, it's better to amputate in a serious infection, and that clears the infection and saves the eye also.
Thank you, sir. Dr. Rishi, I was wondering, I mean, we all know we have to lift the flap, take a scraping from the bed, as well as the back of the flap. In this early case, in case the flap hasn't melted. Now, you would start the patient on antibiotics or antifungals or whatever the clinical suspicion lies before your microbiological report comes in. But is there any adjuvant that you'd like to do once you have lifted the flap, done the scraping? Would there be a betadine kind of a cleaning there, or would it be something that you'd like to use as an adjuvant which might help you?
Well, adjuvants can always be used. And one point I think which I always look at when I'm looking at an inflammation in the flap area is to see if there is an anterior chamber reaction. If I see a AC reaction, that worries me much more. Whether if it's a DLK and restricted to the anterior stroma, there's usually no spillover and there's no circumcorneal congestion. But if I see a cell or two that bothers me, because that means that there's probably a toxic inflammation going deep down into the chamber. So that would kind of heighten my suspicion that this is infective rather than just a sterile inflammation. So that's just one more point to add to the previous question that you would ask.
Definitely.
With regards to adjuvants, I think if it's a small localized infiltrate, I think there is consensus on we should look at it as an infective pathology rather than something which is sterile infiltrate. And you'd start them with, I would think, broad spectrum antibiotics with intensive broad spectrum antibiotics. I'm not so sure about lifting the flap immediately. I guess it's easy to say that. I would probably call him on a daily review and try and take a call on whether I would like to lift the flap and take a culture or a scrape from that area, or even wash out that area completely. With regards to adjuvants, it would remain hygiene and betadine, yes, from a lid and periocular perspective, but not specifically for a intrastromal kind of an infiltrate. I'm not sure betadine would help much in that situation.
Dr. Rajesh, your perspective?
If it worsens, then flap amputation has to be done, because without that, it doesn't clear up. So that is something that one has to keep in mind. As far as interface is concerned, I will not use betadine in interface. Rather, I will use antibiotic in the interface. Flap amputation is something which I will definitely be ready for it, anytime, because many of these cases, they keep worsening in spite of all the treatment. So then flap amputation works in these.
Flap amputation brings me to another perspective here. In a regular LASIK, no infection, and because of melt or whatever reason, or maybe a free cap, you've lost a flap. What is the refractive outcome of that? Ritika? Dr. Ritika? Dr. Ritika?
Unmute first.
Basically, now we have more planar flaps with the femtosecond, and we are very unlikely to lose the flap.
No. The question
However,
is,
the meniscus flap is where the problem is. So you're losing more tissue which is thicker in the periphery. So you're removing like a lenticule thicker in the periphery, like a hyperopic lenticule. So therefore, there is a refractive outcome. Also very important is sometimes we don't lose the flap and we reposit the flap which is misaligned. And that causes much more torque and astigmatism. So you are either removing a hyperopic lenticule in a microkeratome flap because it's not planar. If it's a femtosecond flap, you're not inducing a refractive error significantly. And if it's misaligned, you're inducing astigmatism.
Perfect, Ritika. But what message I wanted to send with that question is, with referrals where there's a LASIK being done outside, I'm not talking about SMILE or irrespective of a femto flap or a microkeratome flap, the surgeon who's referred it, in case we suggest an amputation or removal, they were very apprehensive about the refractive shift. So I would like the panelists to answer that, whoever it might be.
So if you have a flap, like supposing you had a very bad epithelial ingrowth and it's been extensive and you've done debriding, you've done it all, and the flap gets so shriveled and thinned out, it makes sense to remove the flap. And
again, the question is not why we are removing it. If it is removed, what is the refractive outcome?
It does not have a refractive impact largely.
Okay.
These patients all do well. Some of them might have a small hyperopic shift, but actually it is not at all so significant that we need to think twice in those extreme situations.
So that's a message for everybody listening to this, because even if your corneal surgeon advises sacrificing the flap, it's not going to affect the refractive outcome too much.
Yeah, it's
Rajiv, there are two
Yes, sir.
Rajiv, there are two things important. One is a long-term result, one is the immediate result. All those cases where you have lost the flap, maybe because of infection or epithelial ingrowth or a free cap sometimes, or dislodgement post-injury, though immediately they may not be a huge refractive shift, but they do have, a Ritika nicely said, they do have a induction of astigmatism, sometimes become irregular also. And because in the long run, the hyperopic shift will be definitely there in these cases because of if it is a microkeratome induced flap. If it is a femtosecond flap, may not be that huge impact because your flap thickness are not more than 120, 130 in those cases. So there is not a huge report in these cases to see what happens after 1 year, 2 years in these patients. Would these patients have more ectasia? Would these patients would have more epithelial problems? Because now the surface will be epithelium, and how the epithelium grows, how the epithelial layers onto this area is going to induce further, higher order aberrations. So that is the most important part. So given an option, if you have a thickness more than 380 or in these cases of 400, after 1 or 2 years, I might look for a topo-guided ablation for these patients and improve their quality of vision.
Dr. Rishi or Dr. Darak, any questions that you have for the panelists?
Really, I think it's been a very comprehensive coverage of post-refractive complications. I think we've pretty much covered every aspect that we possibly can. I think with the reinvention in many ways, or the re-advent of surface ablations, a lot of shift has taken place from microkeratome or femto-based procedures to surface ablations. I personally have moved a lot towards the surface as compared to deeper in, and just so much happier with my outcomes and the safety that it provides. I'm not sure what the take of the other panelists is on moving away in the lower myopes, especially moving towards the surface, in other words.
Yes.
Yeah, Tom wants to say something.
Yes, sir.
Yeah, you wanted to say something.
The question of Dr. Rishi about how many what the volume of cases you moved to the PRK instead of the LASIK. This is your question.
Yeah, for
Yes.
low myopia, are you shifting more these days towards surface as in comparison to previous times?
Yeah. Okay. Actually, I had talked about the haze, which is regarded to or related to the surface ablation, but actually the old cases at which I shift from LASIK to and the low myopic patients to the surface ablation are the suspicious cases or related to their social and occupational life. I found the PRK will be more comfortable to me before being to the patient himself, because any suspicion which where at any time I'm not sure about my topography or on the tomography of that patient, or about the age at the same time, about the age, also about the marital life. If a young lady who didn't get married yet, I'm preferring the PRK to the flap-related procedures to be safer for her life in the future after that.
I would like to add that I would prefer to do, I wouldn't want to do PRK irrelevantly. I would like to keep it only for thinner corneas or borderline topographies, because SMILE has come in and as it's a major breakthrough and it is such an uneventful procedure. So although, yes, there is PRK has a role for a segment of patients, but I wouldn't want to do it for otherwise normal topography. If cost is an issue, if the patient just cannot afford a Femtosecond also, it cannot afford a SMILE procedure, I would not push him to Ophthalmological. I might convince him to do a PRK maybe.
That is fair, I think, because cost is a major difference between PRK and SMILE. It's probably 4 times. So that would be a major factor again. So what's happening, I think, is in the whole spectrum of myopia, at least, anything below 3.5, many people are moving back to the surface. And people, and beyond 6.5, 7, they're looking at lens-based technologies. So actually the group where flap-based surgeries is really the preferred option is getting narrower in the center of that band. I don't know what everyone else thinks about that, but that's how I perceive it happening.
Okay, it was a wonderful discussion. I guess these things will go on regarding surface. Like a lot of people worldwide, are moving towards surface. Maybe after some time, they will again shift towards some other procedure. So these things will keep happening as long as we are managing our patients properly and providing good patient satisfaction. I guess these things are immaterial and procedures don't matter. So all the procedures are good, I guess. And only thing is that we have to prevent the complications and we have to manage the complications if at all it has happened. So in the end, I would like to thank everyone, Chairperson Titial sir, who has always been the guiding force, and our panelists, the Vice President, Dr. Rishi Mohan, Dr. Ambrish Darak, Dr. Rajiv Mukherjee, and all the speakers, which includes my dear friend Hosam from Cairo.
Thank you.
And of course, Dr. Chitra Ramurthy, Dr. Ritika Sisdev, who is also the Joint Secretary and Joint Treasurer of ICRS. And of course, Dr. Sujata Das, who really agreed within 2 days' time. She told that yes, she will be willing to present. So I thank one and all. I thank all the audience for participating. I thank everyone, and I would also like to thank the office staffs, Kirpal Rana from AIOS and Bageshwar from ICRS, who took care of all this webinar, of conducting this webinar. Thank you very much. Titial sir, the final word from your side, and then we say good night to one and all.
So Rajesh, I appreciate taking this subject, because during the lockdown, when it's going to open, I think refractive surgery is the one which is going to take over all other surgeries immediately, which is, I think, the safest surgery which is going to be now for us, rather than it is safer than cataract surgery today. So I think we have discussed the right point in the right moment, and I hope people have taken some positive points out of our complication management, because as Chitra rightly said, the refractive surgery is one of the safest surgery possible, and the complications are very, very rare. And if you have that, that can be managed very effectively, which we discussed out. And I appreciate the presenters, especially our two friends from abroad. They've done a wonderful presentation, and they've been our friend for a very, very long time. They've been coming for our conferences for the last few years also. Thank you, all of you, and safe days ahead. Good night, good morning, and good afternoon to all of you.
Thank you. Thank you.
Thank you.
Thank you, Rajesh. Thank you, Jeevan.
Thank you, sir. Thank you.
My pleasure to be with you.